Hello, everyone, and welcome to today's webinar presentation. This is Michael Saltzman, and I'm the Director of Digital Products at Blue Sky Bio. I hope everyone is staying safe and staying healthy and staying home during these times. We're continuing our viral dental education webinar series with one and sometimes two presentations almost every day. Please follow the webinar schedule. We're actually still adding webinar presentations. You can see the upcoming schedule on our site, blueskyplan.com, webinars 2020, as well as via our Facebook groups, the Blue Sky Bio user group, and the Viral Dental Education group. The webinars are recorded, so if you have missed any presentations, you could again go to that Webinars 2020 page, click on the link for recorded webinars, see a listing of past recorded webinars, and we can actually send you the CE credits after you complete the 10-question multiple choice test. And just to clarify, if you're watching this presentation live, then there's no need to complete the test. We'll be sending you the CE credits to your email within a week or so after the presentation. If you have questions during the webinar presentation, please type them into the question and answer box, and we will address them probably towards the end of the presentation so we could get through the material and then address questions towards the end. Today we have the honor of hearing once again from Dr. Robert Mickley. You've presented in the past three-part series, the biological basis of implantology, atrophic extraction and bone grafting, implant startup. All of those are recorded and all of those are on the website. And today he is continuing with the topic of sinus lift 101. So Dr. Mickley, you practice in Brooklyn, New York. You're a recognized expert in implantology. You lecture extensively and you run the in-office mentorship program for general dentists with providing hands-on instructions in implant surgery. One of the questions that we frequently get is how long has the presenter been educating, lecturing, and providing educational programs for? Can you provide some background information on that?
Sure. It's a good question. I kind of been teaching since I've been doing this. It was kind of within dental school. We had a lot of presentations. We all did. In residency, we had to do a lot of presentations, and I found it the best way to learn is to present. So yeah, as long as I've been doing this, I've been teaching it, and I started doing as I got into this professionally, got into private practice. I started up a course. It was a couple of years in when a friend of mine went to an overseas program when they hands-on that you do like 30 implants in a weekend. Called me, said I took this course a couple of weeks ago and it was great. And I did so much when I was there, and I got back to my office Monday morning and I don't know what I'm doing now. So can you help me? And I thought, we just spent a lot of money on a course. That's not good that you can't do it. And I realized the way that we learn in school is we learn it didactically. We do it with our teachers there, and then they slowly loosen the leash until we can be out on our own. And the course is just so compact; it's always someone over your shoulder, so you don't really get a chance to integrate it. So I developed this method of teaching within an office concept, just because that's the way medicine is taught in general. So I found it to be the best way to work, and it's been fairly successful.
So in the pre-corona times, what would that program look like? What would the doctor receive? What would you be providing with them with, and how would that work?
It had been obviously face-to-face, not virtual, where people would fly out to a location. It was mostly held in the United States, where they would come to a course, and then we would follow up in their office, where we would go out to within the New York area. We'd go out to their office directly. I would actually spend 1 to 2 whole days in the office doing cases together with people taking the courses. We'd spread it out throughout the United States. We were just going to now, before Corona, it was going to expand outside the United States. But now with this Corona, we kind of have been rethinking how to do things and to reach a bigger audience, because implants are such a big part of dentistry, yet the education we receive in school is so minimum. The concept is to do this virtually and take courses online as we've been doing, which have been a fantastic response. And then do a via satellite sort of mentorship in your office, where You have a Bluetooth headphone in your ear while you're doing the procedure. We've done everything in advance together. And then while you're in the procedure, you have the comfort level of knowing that, hey, I have a question of what's going on here. I have someone I can ask right away in real time.
You'd be watching the surgery, which is being broadcasted to you via camera. You'd be watching the surgery. You'd be coaching, answering questions, how to deal with situations.
As if I'm there, but we can reach. Yeah, and especially we've had a lot of requests of people in kind of out there, way out there areas, rural areas in the United States and just other countries where it would just be impractical for a doctor to for me to travel all the way to them. So this really opens it up to a much broader audience, and just hope to help as many people as we can.
And I think it also provides an avenue that people who are watching, besides the actual dentist who's getting the one-on-one help, they could learn from it. They could watch the procedure and they could learn how to address different types of situations.
Exactly, right. The concept would be, you learn one and you teach one. So while we're doing your live course, with your and your patient's permission, we would broadcast it live as well, or pre-record it, whichever way would work, and then post that for more people within these mentorship programs to learn from.
Okay, that's great. So just one or two more questions, if I may, before we jump into the presentation. You've been using Blue Sky Bio products for quite a while now, I would say, correct?
Since day one, yeah, since residency.
So what would you say is your favorite product or solution that you just can't do without, that Blue Sky Bio is providing? I know there are many that you can't do without.
There are many. To take Blue Sky Bio out of my practice would be like a total rebuild. Trying to think, there's one. I mean, aside from the products itself, the partnered products, the printers I got behind me, I would say the software more than anything else. I couldn't live without the software. An implant, Blue Sky, what they do a great job of is giving you the top of the line implant at a really reasonable price. But an implant essentially is an implant. I can change their nuances about them that are great, but you could upgrade implants and change them all the time. The software is just, it would be like doing a procedure blindfolded without the software.
I definitely agree. I'm not biased at all, but I definitely think the software is the number one product.
I've been using the software since it was in its Atari days. I still have pictures in my old lectures of what seemed so cutting edge, where I had like a pixel block as my implant, overlaying on the CT scan, which the quality of CT scans back then was nothing like we have today. So it was like the Atari mode versus like, I don't know, the PS, what do we have to, PS4? Yeah, it's 5 now.
Yeah, definitely. So just, during this time period, and it's definitely not a simple time period, and it's a difficult time period, and there's a lot of challenges for a lot of people. But if we wanted to look at the glass half full and to look at what we could learn from this time period, or what we could take with us from this time period moving forward, what would you say is the top takeaways that we could use this time period?
Great question. It's tough on so many levels, because this time affords us a lot of great things, but yet is so challenging at the same time. On my own extreme ends, I've got to spend more time with my family. I got to learn all their names. That was a big plus. It's a really quality time that if you could have told me what would you pay to spend 2 months straight with your kids, it's your wife and your kids, it's priceless. So on that end, it's been phenomenal. On the flip side, obviously the financial devastation, and worse, the physical devastation. I lost a friend a couple of weeks ago, 42 years old with 4 kids. Just that stuff is, obviously life-changing in a horrible way. So what it's forced us to do, or forced me to do personally, is really just prioritize life. What is important? What is really important? Not what pays the bills, not what just you need to do. What do you love to do? And what do you really miss now? So I don't miss paying bills. That part I don't miss. But I do miss treating my patients. I do miss teaching in a face-to-face venue, because as great as this is, we've done smaller groups, which I've enjoyed a lot more, in the sense that I get to see faces on the other side. So that's been really great. So I would say just really prioritizing life and prioritizing business. I've had a chance to think about my office in different ways than I could normally when you're just in a day-to-day grind and things are being done the same way. I'm forced now to rethink, how is everything done? and what are we doing because it was just always done versus what makes sense to do and how we're going to go forward in a better way, in a more cost efficient way. What could we add to our office that's going to make more sense? Yeah, so I'd say those are the biggest takeaways, but it's definitely been a memorable time in life.
Prioritizing, realizing what's important, and deciding, I guess, how to move forward.
Yeah, and to really think big picture. That's, I think, the biggest takeaway in life and in business. Big picture. What about life makes you happy? That this is what I want to pursue and want to really focus my time on and my real energy. And in business, what is it that I enjoy within my scope of my practice that I want to do? Have I not been doing things because of fear? And am I ready to maybe take a step forward now that I have extra time to learn things I never thought I'd learned before, and to gain skills that I never thought I could do, just to open up your horizons, the what is more possible today. It's kind of counterintuitive. A lot's been taken away from us, but at the same time, we're given a chance to really open our minds and think. And I think humanity will come out of this stronger overall.
Okay. Great. Yeah, there's so much more to discuss, but I don't want to take up more of your time and more of everyone else's time. So let's get into the presentation, and thank you.
All right. Okay. So as we, time-wise, I apologize to those. These have always been advertised as 1 hour. They've not ever made it to 1 hour, but we try and keep it as close to an hour as possible. So I will be running through a little bit of these. We'll be talking about a more in-depth method of learning the hands-on portion of this at the end. So if you feel like I'm going too fast, write down some questions. We'll stick around at the end to go through the questions. I'll try and field a few during, but we'll try and field most of them at the end. You could jot down my email address as well if you have any questions specifically to email. Michael, if you don't mind just typing it on the question count thing I have in this PowerPoint. It's implant, INPLANT, mss@gmail.com. If you just type that into the question answer, you'll see it there, copy it down, and any other questions going forward, don't hesitate to ask. All right. Good. So adding sinus grafting to your practice. So what I've found that sinus grafting is once you get your first 20 implants under your belt, and what's the next step to do? This is definitely the next step, because in terms of ease of placement, it really just opens you up to doing a lot more. It opens you up to doing more for your patients because you've expanded your skill set. The biggest drawback of this procedure is complications, like anything else. So we're going to talk about today how the sinuses work, what to look out for to kind of understand the anatomy you're getting yourself into, and to see how to best address it. With that knowledge, you end up avoiding most of the common pitfalls for just understanding what's going on. And from there, just placing an implant, if you're at this stage, you know how to do that. So this is just taking that extra step, adding a little bit extra bone where you need it to go, and opening up a lot more we can do with your patients. And with guided surgery, as we've talked about, there have been some great lectures on guided surgery. It makes this procedure much easier. Blue Sky just launched a guided kit we'll be talking about at the end. So it's really one of the stage 2 of your implant practice is, I think, adding sinus grafting. Just a little bit about me. If you haven't been to any of these lectures before, I went to Stony Brook University in New York. I did a general residency followed by an implant fellowship in oral maxillofacial surgery and implantology. I went straight into private practice, focusing on implant surgery. We're a referral practice. We just do the surgical aspect, and we help people along these prosthetic aspects as best as possible. To the extent that in many cases I'll put abutments and temporary crowns on the implants and just give it to the general dentist to take an impression and put a crown on, or they do their own abutments. We do as much or as little as they want us to do, but we don't do final restorations. And then we have our mobile surgical solutions within the New York area, where we send some of my associate doctors out to offices within New York, New Jersey, Connecticut, to handle your surgical cases in your own office. And then the implant tele mentorship program, and I put the tele in parentheses because that's what we're launching now, is where we're going to do a full-on mentorship program from the comfort of your own home or office, followed by the in-office aspect done virtually.
And is that offer for the first surgery free still?
Yes, that is still, I have not received an email from anyone worldwide saying we are placing implants yet. So I heard some states in the United States are already going to open up on May 1st for elective procedures. So if you have a case that you have ready to go, we will need a CT scan and some other basic information. Shoot me an email, we'll get the case planned, and we'll hopefully broadcast it here in the next couple of weeks. And again, first case, whoever gets it in, 100% free. Okay, so we're going to talk about the goals. We've talked about this in the past. The goals remain the same. We want to get our patients into optimal health, dental health, and function. So we're always going to envision the goal, and then the methods of how we get there is always going to change. And again, we want to have as many tools in our belt to be able to know what to use in different situations. We never want to limit our patients' care based on our own limitations. Try and add whatever you can to your own repertoire, but know what's out there. That's probably more important than anything else, because if you know what's out there and you know what you can refer for the optimum care, do that. And then when you're ready to, you'll add it into your own practice. But don't limit the patient's treatment based on lack of skill or lack of knowledge. So the goal of a sinus lift is to encourage the body to create bone on the floor of the sinus where there's currently insufficient bone to support dental implants. And we have a pneumatization of the sinus where the sinus drops down into that spot, as we see on the screen. And we need to graft that bone to replace what was lost and then place an implant into that area. And pneumatization of the sinus, what that means is a decrease of the alveolar bone volume due to either an anatomical variation, or if you see on the patient's right hand is the anatomical, patient's left hand is the continued air pressure and the sinus cavity due to the lack of opposing dentation. Basically what's going on, if you remember the earlier lectures, if you were there, we talked about the osteoblast and osteoclast symbiosis, how they're both going off of each other. So when there's osteoblasts in the area, then they're replacing what the osteoclasts are taking away. And that's how our body is constantly turning over bone. Every 2 years, we have a brand new skeleton. But the osteoclasts are working first and the osteoblasts are in their wake. So when you have teeth and you chew, the osteoclasts are taking away old bone, but the movement of the teeth is stimulating the adjacent bone to recreate new osteoblasts. When those teeth are removed, what will happen is the osteoclastic activity is still there, and you have pressure from the sinus pushing down. So that will stimulate those osteoclasts to destroy bone, but nothing to stimulate them to regrow. So that's where you have a pneumatization of the sinus. And it doesn't happen to everybody, but it happens to everyone to some degree, but some is clinically insignificant, some is very significant. So that will change between patient to patient. But if you see in this patient we have here, even their anatomical side, already the sinuses are pushing right into the apices of those teeth. So this is someone who, as soon as that tooth's taken out, and you have to be careful of these, is that these are the ones that are primed for an oral enteral communication by doing everything right. You've taken out the tooth well, you've done the atraumatic extraction as we described it, you did everything perfectly right, and there's still a hole left into the sinus because the anatomy was so. If you don't take a tooth out well in those cases, you end up breaking bone, now you've got a massive oral enteral communication. And we'll talk about those in a little bit. What are the functions of the sinus? Just why do we even have these air pockets in our head? And these are just important to tell our patients why this is there, because we have to educate them of what their anatomy is and what they'll need for us to be able to place implants for them. So one is voice resonance. And when we all have a cold, especially with nowadays a really bad respiratory infection, the voice resonance changes significantly. So it resonates in our sinuses. It lightens the skull. If we were all solid bone, our heads would be a lot heavier. So that helps lighten the skull as well. It filters the inspired air as well by having the mucus catch what's coming in. It moistens and warms the air as it goes in as well. And it provides some thermal insulation for some of the more sensitive tissue, the eyes and the brain, the frontal sinuses. So that's basically the functions of the sinus, why we have them. This is just a straight section of the sinus, just to have an idea of what we're looking at. So the maxillary sinus is a large pocket over here. But interestingly to note, the first thing you got to be appreciative of is that there's one place for the sinus to drain out of, and it's a pretty small opening. it's called the osteomeatal complex, which is basically this whole area over here of the ostium as the alveoli comes out and then drains down into the nasal passage. Really, really small opening. And what's happening is it's got to work against gravity to push the mucus out. And you can appreciate if you have a sinus infection, what that will generally mean is this small area is being occluded by something, usually inflammation, but it could be by anything. And that would cause a inflation. So it's just, again, important to understand how this is working and what kind of small opening we are dealing with. And the risk of complications you can see are quite high just due to the anatomy. This is a plastic model, which is the one actually we use for teaching. These are great. You can pick them up on eBay or on Amazon. I think they're a little bit cheaper on eBay, which is basically a plaster jaw with the sinuses and some like latex in the inside, just to be able to mimic the Schneiderian membrane. And we use these for teaching all the time. They're great because you can look into the sinus and see what you're doing. When we do it as a lateral procedure, it's not a totally blind procedure, but it's kind of blind because we're making a really small window. When we do a crestal lift, that's totally blind because we have a couple of millimeter opening to be able to get our implant into. So it's basically a blind procedure. So to be able to really appreciate what's going on in the sinus and not act blind in terms of understanding what we're doing. So these are great teaching tools. So if you want even just to try it out on your own, just hop on eBay or Amazon, type in implant or sinus model, and you'll find one up there. But just understand the walls of what we're dealing with, the cavity we're dealing with. So we have an anterior wall and a posterior wall, a medial wall. So that's going to be the far side. When we're talking about lateral lifts, we're going to be lifting this mucosal layer all the way over towards that medial wall. We also have a lateral wall, and that's the lateral sinus lift procedure. It means we're opening a window into this lateral wall. We then have the inferior wall, which is the floor of the sinus, and that's what we're going to be addressing when we do a crestal sinus lift. And there's also a superior wall on the obviously far top, and that the superior wall of the sinus is also the base of the eyeball. So we have a lot going on in a very small area, and a lot can go wrong if you don't know what you're doing. So that's what we're here for. You gotta learn what we're doing. Good. Okay, so this is just a CT cross section with the same idea, just showing how the drainage works. And when we talk about sinus surgeries, what they're doing generally is opening up that passage to be a larger passage for things to be able to drain out of. Some great YouTube videos you can watch, sinus surgeries where they're doing it with a scope, and it's really pretty impressive how they'll go in through the nasal cavity and go into the maxillary sinus all the way through there, and then take a sharp right or left, depending on which way they're going, into the maxillary sinus. The arterial supply going on, it's innervated all from the outside of it. Because it's an air pocket, the air pocket itself does not have any veins or arteries inside of it. It has the outside of the bony windows into the mucosa, but obviously the air pocket doesn't have any blood in it itself. But we have the facial artery, the greater palatine, the infraorbital, and the maxillary artery. And the dotted line you see on your screen there, that is a branch of the PSA, which oftentimes if you're doing a lateral window technique, you have to be aware of, because that can come into play. And if it's cut during surgery, it'll end up just causing a big mess. It's not the sort of artery where someone's going to bleed out from, but if you have a lot of blood in a pretty closed procedure, makes for some very difficult tiding. So nowadays with CTs, we can diagnose where that is before we ever get started and just look to avoid it. Innervation, again, this is basically branches of V2 innervating all throughout the sinus. The physiology of what's going on here. So we have a layer of mucosa, which is basically respiratory mucosa. It has these globulate cells with cilia on top. Cilia, these little hair-like structures that are constantly beating. If you remember, the osteomeatal complex is all the way at the top of the sinus. So how does gravity pulling mucus and debris down, how does that make its way out? So these cilia will beat up and up and up and drag that mucus up with it, and then it will then expel it from the outside of the sinus. But what it's doing is trapping all sorts of debris, bacteria, viruses, and the like, and not allowing them to infect our bodies, or at least minimizing the chances of it. So it's, again, lined by respiratory epithelium, ciliated And it's called the Schneiderian membrane. I'm assuming that Dr. Schneider was the one that first named it. And again, it's going in an upward direction to expel the mucus out. And again, this is just a quick idea of what's going on drainage-wise. Again, working against gravity, so it's kind of constantly got to push its way up and up and up. And if we see that here, just the flow of what's going on, all the walls are pushing up out of the osteomimetic complex, up into the nasal passage, and the same thing will happen. The frontal sinuses push all the way up, and then also push down into the nasal passage. And this is just seeing in two different directions. You're seeing the cross section as well as the frontal section, seeing how it's pushing up and then pushing back inwards towards the nasal passage. So that's the very basic flow of direction. And there's, again, important takeaways is to make sure you don't put anything too big into the sinus. Our goal is never to go inside the sinus. We're going into the sinus cavity in terms of the bony cavity, but we don't want to go into the mucosal cavity. We never want to get involved there. If we do, we have a perforation, which we'll talk about. That's the biggest complication of this procedure. But it will happen eventually. You do enough of these, you will have a perforation. It's not the end of the world. You just want to make sure you're not putting anything in there that can get stuck in that osteomimetic complex, because that will, by definition, cause an occlusion and not allow anything to go out. So we're going to talk about the type of grafts we're going to use, the size of particles of the grafts we're going to use, certainly stabilizing our implants so those don't get stuck in there. But just all ideas, once you know where you're going and not just working blind, you have an idea of where you want to get into, and avoid most complications just by having an appreciation for that. And again, just seeing a healthy situation here on the left-hand side versus an unhealthy situation, and a little bit of inflammation can end up occluding this pretty quickly. And then you'll get things that are trapped and are unable to drain until the inflammation goes down. And just, I found this online, I thought this was great. What color is your snot and what does it mean? So clear, gray, you're healthy. White is generally viral. Yellow or green are generally bacterial. These are not hard rules, but they're generally. And brown or orange means there's going to be some blood cells in there or some dried blood. I tell all my patients after this procedure, what I know, it happens very infrequently. They will have a bleed of any kind. But I tell them to expect to have a nosebleed after this. And the ways to prevent that is, and I'll give them my post-op instructions, which we'll go through, but I'm always telling them that things are going to happen bad, and when they do, call me. So that when they happen, they don't freak out that things are going terribly wrong. But if I tell them everything's gonna be great and things start happening, then again, you're apologizing after the fact instead of informing before the event happens. So just the concept is a carpenter can do a procedure, but a doctor must manage the complications. Wood does not get complications generally, but human bodies quite often do. And before we even talk about the sinus lift procedure, just because you see a pneumatized sinus does not mean that you need to do a sinus lift. First and foremost, you have the option of doing a bridge. So avoiding surgery altogether is one option. If that's in the patient's best interest for any number of reasons, that may be the best way to go. But realize just because there's a pneumatized sinus doesn't mean that it always has to be grafted. It only helps, it doesn't help the patient's sinus. They can have an enlarged sinus that will make no difference in their lives. The only reason we're doing this procedure is to add bone in order to stabilize an implant in the area. I remember one of my oral surgery attendings, we were just taking out a bunch of wisdom teeth, and I asked him, why are we taking out this patient's wisdom teeth? He's like, because they're there. So we don't want to act like that. We want to take them out only when the patient needs them out. So we want to do this grafting procedure only when they need that to happen. So alternatives, the two biggest ones within the implant world are the short implants and angled implants. So short implants, they can be manufactured between 5 and 6 millimeters. Blue Sky makes a fantastic 4.3 up to 7.0 body by 6 millimeter length. So you have a lot of options within the short implant world. And we talked about in the implant, earlier implant courses, where implants are not a length to, root to crown ratio, the same way as a tooth is, because we're working with surface area of bone. As much bone as I have touching my implant is going to be what's the determining factor of how strong that connection is going to be. So a shorter but wider implant is the same amount of stability as a longer and thinner implant. So if you have less thickness, you go a little bit longer. If you have more thickness and less height, you go a little bit shorter, and they will compensate, the length and the width will compensate for each other as one decreases and the other increases. So short implants are definitely a good option. Not as good an option in the maxilla, only because as we talked about last time, the type 4 bone we find in the posterior maxilla is the softest bone. So you really want as much support as you can there in most cases. There are times when a short implant is warranted. And if you have great width, that may be the case. But I'm much more comfortable putting a 4.3 by 6 millimeter implant for a molar in the mandibular than I am in the maxilla. And this is a situation where a patient had a previous significant sinus infection. And that's going to be one of our, certainly in your earlier times of doing these, someone who has general sinus pathology, which means they have their ENT's number on speed dial. I ask them, do you have any sinus issues? And if they say, what's that? They don't. If I ask them and they say, oh yeah, I'm at my ENT a couple of times a year, or it's seasonal and I get it every spring, or I get it every winter, then I'm going to not want to do this procedure when their sinus is most active in terms of having to fight off inflammation to begin with. But this patient had a previous sinus infection. So we looked, okay, what are our alternatives? If you go straight up and down, the best place to put this implant is with a sinus graft. But can we move around that? So this is in the slightly olden days when if you look on the bottom left-hand corner, the patient is actually wearing an impression when I took the CT. And this was called the Ferguson technique. Rick Ferguson came up with this ingenious method of getting an SCL file off of a PVS impression. It's great videos on YouTube. I'm not going to get into it too much here, but that's what we were doing in a case like this before my intraoral scanner. We then prosthetically we'll work up, make sure that the implant's going to go into the right spot. I just saw my power is getting low. Just make sure everything is plugged in properly. Give me one moment. Sorry. That's what happens with live surgery.
I'll just take a minute and I'll fill in the time with some information regarding some updates. So even though we're dealing with this difficult and strange time period, Blue Sky Bio, both the digital side and the non-digital side, is moving forward on many different fronts. We expect to have a software release coming that's going to have, what we have on the screen actually, the crown and bridge updates, the export to XML configuration file for milling, and many other updates. And I'll just say that we have some updates and some new directions coming. So just stay tuned. And Robert, everything in order there?
Yeah. Yeah, plugged in, everything is good to go. Good. So we do a prosthetic workup. We talked about this last time as well. This would actually be a great case for an ortho evaluation here to do some minimal trays, could get this patient lined back up. And my immediate concern for a molar is that rotated posterior molar. If I could rotate that and bring it back in, I can have a much better outcome. But this patient was not interested in ortho. So we're going to be doing a prosthetic workup. And now, can my implant in the bone that's there support that crown properly? And that's going to be my question. So if I can do that, then this is a good way to go. So a short and angled implant will be advantageous to not get into an additional risk of entering the sinus with a recent sinus infection. This is just the case afterwards in the placement. You wouldn't know that this isn't straight up and down. This is placed ideally and should be restored ideally as well. If you look, one of my favorite things to see is when I take off a healing abutment and we see the nice beet red color. We talked about this at length. This was probably my biggest question from my last round of courses. And if you have questions about that, you can drop it in the question box. We could talk about it briefly, but in the last few lectures, you can go back on YouTube and review. We talked about that at length. But anyway, soft tissue is, you see we have ideal soft tissue here as well in terms of the buccal corridor. So this is within the given bone. We could place the implant ideally without having to do a sinus lift. So we'll always look at that if the sinus lift is not an ideal situation for our given patient. Or we can always angle them the opposite direction, and the more commonly done LN4 procedure. And when we do that, we end up with a great situation as well. We oftentimes, when we're immediately loading a sinus grafted immediately placed implant is not a good one to load because we have soft bone and limited capacity to begin with, and now I have grafted bone, which is not giving me any support. So the odds of failure of that is quite high. So I oftentimes, when I do an all-in-4 procedure, I rarely will do 4. It's usually more 5, 6, 7, 8, as many as I can get in that will best support the patient. And again, when my implants are, the max implants, I get them in a 5-pack for $500. So for an extra 2 or 3 implants on a full arch case that I can sleep well at night, I don't even hesitate. I get as many implants in as well-spaced implants in that makes sense. So, but I will do this all the time, angle implants and avoid the sinuses altogether. But if I needed more, I would do a sinus graft at the same time as the procedure and just not load that until everything heals up. But angled implants are also fantastic, either with multi-unit abutments or without multi-unit abutments. They both work really well. And I just show both of these. If you see the one on the patient's far left, that is a milled abutment. That is not a multi-unit. And we can get these angles in really, really well with milled abutments. You don't need multi-units in many of the cases. Good. Okay. So now that we talked about alternatives, we just want to open up our minds in terms of treatment planning. And again, within the courses, if you've followed me until now, you know that treatment planning is where it all happens. We don't just want to drill a hole and put an implant. We want to treatment plan these well. So the more ideas you have in your mind of what can be done, the better clinician you're going to be. So maxillary sinusitis is our #1 complication. It's an inflammation of the maxillary sinus. It's a headache, usually involving the sinus. A foul-smelling nasal or pharyngeal discharge is very common. Possibility of some systemic signs of infection, such as fever or weakness. Pain and fever are very common. Referred dental pain, we know that is very common. And again, it's maxillary sinusitis only means there's inflammation. We don't know what the cause is yet, but we have inflammation. So if it's after a sinus procedure, that could have been the cause. If it's before a sinus procedure, we haven't done anything, sinusitis is very common. And referred dental pain is our most common situation. But there's always fluid building up, and it just can't drain out of the osteomated complex. Different causes for it. I'm not going to get into great detail here, but all the extrinsic causes, which means things outside of the sinus that are entering it to cause the problem, versus intrinsic causes, which are things within the sinus itself, which are not letting things to drain out. And sinus surgery is usually done for an intrinsic cause, which means there is a structural issue. Either the septum is deviated or some of the other drainage areas are just too small, either the soft tissue or the hard tissue, and those are opened up in the sinus surgery to allow that to happen. That's handled by an ENT unless that is your specialty. Refer that out to the ENTs. And again, management of these medical versus surgical. We're generally going to do medical in our fields. Sometimes we'll enter surgically, but again, this is not for the light of heart. This is if you really know what you're doing with sinuses. I actually have an ENT right next door to me in my office. So I learned a lot just from asking questions, and I've just gone over there to observe with downtime, watch them put in scopes and just watch what's going on in the sinus, and just learned a tremendous amount. So surgically, will set everything for them to do with the scope through the nose. They can see everything really well. It's a really cool idea. The FESS procedure, which is where they're taking a scope and putting it in the nose and seeing everything in real time. It's pretty amazing. I'd love to have something like that in for the lateral window of it, but for most part, it has not been necessary. Okay, oral antral fistulas. These we are all aware of in dentistry because they are not an uncommon occurrence. Generally, most people have seen them small, but they can get quite large. This is we talked about a extraction, even though it's done well, the anatomy lends itself to, say the apex was paper thin, so that's a tiny oral antral communication, but still has to be addressed. And we'll talk about that in a little bit, how we're going to address it, but we don't want to stuff particles in there, grafting particles, because those will push right up into the sinus. Once you have a hole there, almost certainly you have a tear in the mucosa. So once you have that, it's going to go straight up through and can cause something to get stuck into the sinus drainage complex. Larger oral antral fistulas are addressed a little bit different. They have to be addressed surgically, and the really large ones, just again, if you're not eating lunch right now, I hope you're not. this is just going straight up into the sinus. These were fairly common with heavy cocaine addicts. The cocaine actually burns a hole from the floor of the nose down into the oral cavity, and those are cancer patients where they've had to remove large amounts of tissue around a tumor. Those are usually treated with obturators unless they can get enough grafting, enough closure that we can put implants into. But that's the concept. So oral enterofacial management. So if it's less than 2 millimeters, it'll generally spontaneously heal with sinus precautions, which we'll go through in a moment. More than 3 millimeters, you generally want to close it up surgically to not allow that air to pass through. Because if air is constantly passing through, or food or drinks or whatever, it's constantly passing through, that will never heal and will end up forming an epithelial layer in between them. So every time the patient drinks something in their mouth, it comes out of the nose and they blow their nose. It's a mess. So we want to definitely have that closed up. And what are my sinus precautions? And if you shoot me an email, I'll be happy to email this to you. You don't have to frantically write it down. You want to just, biggest things I tell them, they're all written down and I give them to them. I do that in general because they're not listening to me then anyway. It's right after surgery, so I give it to them before. I reiterate it right after, but they have it on a piece of paper. So, and I tell them, please read it when you get home because most of your questions will be answered there. But I tell them most important things is not to blow your nose with your mouth, not to blow your nose vigorously. And when you sneeze, sneeze with your mouth open. Because again, what's happening when we close our mouth to sneeze, we're forcing air up, out, through, and we're putting pressure through all walls of the sinus. So if we have a recent tear, we don't want to put extra air pressure through there and not allow it to heal well. So those are the biggest things. And if they're smokers, obviously I just tell them smoking is just bad for everything. So please avoid it. Those are the most important. This is a more advanced complication. And these can get quite advanced if they're not caught early. And sometimes even if they are caught early, they can swell quite a bit and they can get infected and they can get very messy. I will say, since switching over to, I would say, I don't know, 90% crestal sinus lifts versus lateral sinus lifts, the morbidity rates are significantly decreased. I'll see a case like this once every few years after a big lateral lift that went wrong. This is actually not a case of mine, found this online, but this pus draining out of the sinus, if it's got nowhere to go, it's going to go everywhere. So it's what to be aware of. But nowadays, if you're doing a crestal sinus lift, this is almost unheard of. But just again, you want to learn the extreme cases. So when the mild cases present, they're not scaring you. And again, this is a case that I showed earlier of the patient with the sinus infection, and that was sinus infection that I had something to do with because we did a crestal sinus lift and everything seemed to go well. We lifted the sinus, we got the nice dome of tissue. You can see the outline of the Schneiderian membrane here. We also have the nice dome of bone and everything looks good. So we put in our implant and everything looks good. It even looked so good that it looked like this pushed a little bit of the floor of the sinus tissue up here. And it's still, everything is well contained. So I'm thinking this is great. We'll see this patient in a couple of months and everything's perfect. 11 days later, though, I'm seeing things are not going well. Patient's got pain, has got some swelling, and I'm seeing even radiographically, which is not common so early, is things are letting go. They're not getting stronger. They're letting go. So we remove the implant, and you can see on the CT scan how much fluid is filling this sinus. So we're all the way up to the top of the sinus, and a patient can have sometimes 90% of their sinus filled with fluid and have zero symptoms. Why? Because the OMC is totally open. So if that is open, that's not going to cause a problem. But once that gets just past there and it's got nowhere else to go, that's when these symptoms will begin. So we're looking at it from every angle, and then we're looking at it here from the straight on angle. We see it's totally occluded, and this is a just total mess. So what we need to do is allow this to calm down. We're going to prescribe antibiotics and anti-inflammatory medications, and hopefully it will resolve with that aid. And again, this side is wide open, and this is what you're looking to see. And the other side is quite closed. And we can't even put an arrow because everything is kind of jostled and an inflammatory mess. And again, this is just a simple extraction case. I'm going to take out the roots. Everything looks great. Very, very thin walls you can appreciate. And that's the case we showed earlier with already we have an opening. So when we have that opening, we don't want to put graft material right into that. So what I'll do is I'll take a piece of collagen. I will put the collagen in there as a floor first. Then I will put bone graft material on top of that, and then some collagen again to cover over, and some stitches to hold everything shut. But this will not allow the bone graft to migrate through that opening. It'll cause a complete seal. Again, I'll give them sinus precautions, but with just a small piece of collagen, and if you're not doing a bone graft, probably means you haven't seen our first course of the importance of bone grafting, but assuming you're not doing a bone graft, then still put in something, gel foam, collagen, something to close up the area, and you will be far better off in terms of just the communication. Again, sinus lifting, what you also want to do is identify your neighboring lesions. It's really important because the same, we talked about this with implants. It's as important, if not more important, when you're doing a sinus lift, because if you have existing bacteria here and you're moving things around, so now something was contained in a cyst and you're going to start moving the mucosal layers around, you can very quickly get into that infection traveling over to your new graft and your new implant and cause a mess. So this patient was treated with an old case, treated with an Apico before the implant was placed, crestal sinus lift placement, and the implant went in. You want to clear all pathology in the area. That was a case where you needed to do an Apico or do an endo. This is just a case where that tooth, the patient can say, well, I might want to crown that tooth one day. I might want to redo the root canal one day. I might one day want to do lots of things, but today I can't do the sinus lift when you have a lesion so big, asymptomatic, but a lesion so big that it already has caused a perforation in the floor of the sinus, and the entire floor of the sinus now has a bubble of pus. So if I go in there with any kind of sinus lift, I'm going to end up releasing that into the whole sinus and causing a mess. So that tooth first needs to be extracted as a standalone procedure. Let that sinus calm down, let the infection completely clear, give it a week or two, then come back in and do this procedure well. You don't want to deal with angry and sick tissue. You want it to be nice, healthy sinus schneiderian membrane tissue to deal with. The sicker it is, the more friable it is, and the more difficult it is to work with, and the higher chances you have of perforations. Okay, lateral versus crestal. If you're new to the procedure, don't even think about laterals. It's just a more difficult procedure, and again, most cases can be addressed with a crestal lift. But I would say if it's on the fence, early on, refer them out. At this point in my training, I don't know that I would have enough cases to get good at this procedure again, because I could do almost everything with a crestal lift, unless there's a paper thin tissue, 2 millimeters and less. Even 2, I can squeeze them in if the bone is dense. I'll sometimes open up a window and then do the crestal lift anyway, but I could just see the window where it's open and I could see that the implants are stabilized before leaving it alone. But lateral lifts, just put them aside. Know that they exist, but put them aside from now if you're new at this. But the internal crestal sinus is what we're going to be focusing on a lot more. Where we have sufficient bone, and again, I leave it at 4, but I would even start with 6. I say 6 because when you start off your first few cases, you want to have it that if you get a perforation of the sinus, you can still place a reasonable implant and not have to abort the case and come back. Because when the sinus membrane gets torn and you have to come back to it later, you have a higher chance of it getting torn again. And you don't want to just start this patient on every 6 months they're coming in and getting their sinus membrane torn. So in most cases, then choose a case of your first one where you could place an implant anyway and lift the sinus to get good at it for the first few times. That's the best way to learn. I did my first few cases when I was learning the crestal lift. If they had 8 millimeters, I would put a 10 millimeter implant in. If they had 10 millimeters of bone, I would put a 12 or 13 millimeter implant in. I needed to learn the procedure, so I would give them a longer area to deal with, obviously when reasonable, but I wouldn't charge them for it. I just needed to get cases to get done. They would get a longer and stronger implant. So it was a win-win, but that's how I urge you to do your first few cases. They can get an implant in now, but do the lift to get a better implant in. And again, we'll just show you the lateral approach to it because you can better understand what's going on. Because again, the crestal sinus approach is quite the blind procedure. So we'll open up a window. This is done either with a high-speed diamond, round diamond burr, or with a piezo instrument. In the beginning, I was taught with a high-speed diamond. Then I got a piezo and learned to do it on that. Now when I do lateral windows, I will actually do a hybrid. Piezos take quite a long time to work. So what I'll do is I'll do the outside layer with a diamond. And then when I get to the deeper layer past the cortex, I'll then do that with a piezo. But the idea of the piezo is that it vibrates very quick on the surface of the bone. That vibration causes friction, which is then going to cause the bone to get cut. But the idea is it needs to be hard for that friction to happen. If there's soft tissue underneath it, that tissue moves. And when that tissue moves, it will not absorb that friction and will not cause a tear. If you lean on it, it will tear it anyway. But it allows you to very gently paint over top of the membrane and not cause a tear into the membrane. It's a very good tool to use. It was built for brain surgery where they would cut through the skull, and you can understand why you wouldn't want to saw that close to the very soft brain. So they developed this tool to be able to cut through the layers of the skull and not damage the brain in the process. And again, this is showing a case here. We'll open up the lateral window. And again, this is just to get a point of reference. This is the side of the patient's cheek. And as you elevate, you start to see the outside of the sinus come into view. This is generally what you're used to seeing for most sinus surgeries. You're opening up the flap much higher and getting onto the side of the sinus. And I'll do all these measurements on a CT scan in advance. So I'm not just looking for visual landmarks. I've measured everything out where I want to go. I'll then take the ball out of the sinus, cut out a window. Once that window's there, you can press on this bony area and you'll see it go in and out. And that's how you know it's detached from the walls. Once that's done, I put on a disc attachment to the piezo, and the disc attachment, what it does is it'll separate the mucosa out from the inside part of the bony structure of the inside of the sinus. The outside is mucosa. There's a layer of periosteum against the bone, and you want to separate those two. So what we'll do is we'll separate that with a disc, and it's also pumping water in at the same time, which also helps create some hydraulic pressure, which is evenly distributed around on the whole window that you're working with. And then some curettes to lift up the tissue from the floor. And then in most cases, I'll also, unless again, it's so thin that I can't hold on to the implant, I'll place the implant at the same time also. And the implants are helpful because they will further keep the mucosa up and not allow it to drop back down. Then I'll usually put some membrane on the top of the sinus, which means I will slide it on top of my implants, and it kind of acts as an extra barrier on top of the implant so that when it drops back down, it's not pushing against threads of an implant, which are a little bit harder. Plus, even though I visualize I don't have any tears, or if I do, this helps cover it. But even if I don't see that I have any tears, studies have shown that there are micro tears there, and it's much more susceptible to tearing again and further when you close up. So that will actually kind of serve like a drywall on the top of the sinus. Then once that's in, you can see that right on top of the sinus is here. There's a piece of collagen. Then I will place some graft material, and we talked about graft material in detail in the last few lectures. I'm going to skip over tonight completely. Pack that in, and this is just the opposite side of the same patient. I had a retained root tip I want to get rid of also before we place our implants. Place our implants there. There's a post-op with the implants placed, the sinus graft present, and we have a nice dome of bone that's there. This will drop down about 25% by the time everything heals, but then I'll have nice solid bone when I'm finished. This is just a case of that branch of the PSA we talked about, that's sending a branch through there. If I did this with a high-speed diamond, it would cut this and I'd have a major bleed, major for a small area, where I'd be suctioning out like crazy here, where I don't want to put a suction into the sinus because the suction can tear that sinus easily. So it just creates a messy situation. So the piezo is great for being able to dissect out something like that and avoiding it. We can just move around it and not have to deal with that sinus itself. We don't want to have a bleed, also we don't have a tear. And this is a tear, and it will happen. You do enough lateral lifts, you will get tears. It's just inevitable. Some people have thick tissue where you could push on it really hard and you're not going to cause a cut. Those are great. Some people, you look at it the wrong way and boom, it's open. And the more you push on it, the more it tears. I rarely will abort a case anymore because I just learned how to manage these. But in a case like this, this is one that I would look at and say, maybe let's regroup. But this is basically looking in from the bottom portion straight up into the sinus. That's probably the superior wall of the sinus, which is the where the orbit sits. And again, this is just a complication post-op. The graft got totally out of place here. on one side, and the other side probably the same. Double infection and just a total mess. And again, it will happen, and you'll have to open that up, drain everything out through the same opening that you made, let everything drain, and then hopefully it will live to fight another day. But again, when you're doing these cases for the first time, that's the scariest barrier to entry I find for doctors is, I don't want to do this because how am I going to manage a complication? So the whole idea of what I'm doing with a program like this is I'm giving you your backup. The same as you didn't want to do your first occlusal amalgam because what if you pulp out, right? And we we're all scared when we first did our first one, but you can only do it because we learned from somebody else who's going to be in the room when we're doing it. So if something goes south, they'll be able to tell us. So first is we want to avoid things going south, but then if they do, you want someone there who can help you manage these cases. So if you have a good relationship with a local surgeon that you work with, that's great. If not, virtually or otherwise is always a big help. Okay, we're going to skip this whole section on grafting. You can see that in the earlier videos we've done if you haven't seen yet. It's important information, but just not for now. Skip all the way through this. This is exactly the same slides we did before. Okay, post-op complications. We talked about hematoma, edema, pain, and infections. Showed this, we showed the infections, and we don't want messes. Also avoiding messes before they start. When I start with a patient and I take a CT scan and I see this, I know that there is already a bony dehiscence in the floor of the sinus before I ever started. So I'm going to have to do a split thickness flap just to open this up, because if I do a full thickness flap, my scalpel is puncturing the Schneiderian membrane before I ever started. So you got to diagnose these in advance. And this is one where, yeah, if you've done less than 100 lateral sinus lifts, don't touch this. I remember I had one of these early in my career. I referred it out because to another surgeon friend of mine, because I just said, this is just, I didn't want my, first big complication early in my career on a case that was extraordinarily difficult. So I referred it to another friend of mine who's many more years my senior, and I went to his office to watch the procedure because I was very interested, and he perfed. So I was glad that I punted, but I helped watch the management of the perforation. We still grafted, it still got done, the implants got placed after everything healed, everything got managed, but it's just important to know how to manage these before getting started. Okay, septum are also really important to diagnose in advance. If a septum is there, it's basically a wall splitting one sinus cavity into two different rooms. That's the basic idea. And when you do a lift, you'll lift them each separately because they have different areas to come into, and they're each lined with their own membrane. So if you're doing a crestal lift, you have to avoid it completely because you can't drill right into that septum because the septums are thin. It's going to be thinner than your implant, so you have to avoid it. So you're going to have to place your implant mesial distal somewhere around it to avoid it, but you have to know what's there. Again, it's just the same septum from a different angle. And you see there's much more inflammation in the anterior portion of it than in the posterior portion of it, because it basically creates two walls within that same sinus. And this is how we're going to measure the crest of the sinus. And this is one where it's, just a hair over 2 millimeters, but it's also wide. So this is one where early in my career, this is a lateral lift. Last several years, this is still a pretty straightforward crestal lift for me, but I'm also going to diagnose what is this on the bottom, and you're going to have some fluid to most cases, you're going to have fluid on the floor of the sinus, and you're going to want to know, is that just some fluid on the floor? Can I ascribe it back to a tooth that's in the area? Is it an infection per se, or is it just some low-grade inflamed tissue? In the first several of these, I would email or bring over next door to my ENT neighbor and just say, hey, is this something that concerns you? And what I found out is there's very little that concerns ENTs that are there chronically asymptomatically. Very little things they just say that the sinus is one of the sewers of the body, right? We think of the large intestine as being the biggest sewer, but the sinuses are not far behind it. It is harboring fungus and bacteria and viruses for years in there. The body just walled it off. It's not going to bother you, but I'm going to put it down here for safekeeping. But if I come in and I jostle things too much, I may start up a mess. So you have to just be aware of what's going on and case to case be able to diagnose what's going on. So you're going to rule out sinus pathology, inflammatory, infective, cancer, polyps. A CT scan is an absolute must, in my opinion, when you're doing your first several sinus lifts. I think we talk about standard of care. It's only standard of care when someone gets sued and loses because they didn't use a CT scan. That becomes the standard of care, but it's just a good idea. If you have access to it, which most of us do, even if not in your office, you have somewhere in your city that you can send them out to, it just makes your life so much easier. So I highly push it on, and I wouldn't help someone through a case without it, because if you're doing your first case without using the technology available to make sure to avoid pitfalls, it's just, you're getting yourself into trouble for no reason. I've done them early in my career where I was moonlighting at different places during residency and just the CT was not reasonable. And I did it and we got it done, but you just are leaving yourself open to many more complications and the procedure is just that much more difficult. Anyway, post-op, normal presentations, we have a very low infection rate. But again, if it could be as high as 5%, we talk about Corona now being 2 to 3%, and that's a big deal. We're not going to be treating as many patients as Corona is infected, so we have to worry about it being anything like that. But you do have an infection rate being low, but being there. So you're going to do enough of these, it's going to happen. Swelling, ecchymosis, some minor nosebleeds being present, and mild to moderate discomfort, and they'll generally spontaneously resolve. And again, I read them the Riot Act before the procedure, so that after the fact, I'm not apologizing for something that's going wrong. Just said, we knew this was going to be 2 to 4 weeks to feel back to normal. And then when they feel pretty good after 2 days, you're a genius. But if you said 2 to 3 days, you should be fine, and then it takes 2 to 4 weeks, then it's something went wrong and you didn't do a good job. And then you're going to be looking at yourself saying, hey, what could I have done better? When really you did everything right. They're just in that category that was the higher percentages. If the acute spontaneous pain is present, it's a warning sign, and you should, again, investigate that promptly. Don't wait for it to get really bad. If it's acute and spontaneous, meaning it's 2 or 3 days fine, and then it got really bad and now I'm having trouble breathing, don't wait for it to get much worse. My feeling is I can always put implants back in, but the longer a bad implant sits there, the worse off I am. So I will take out implants if I'm suspect, probably more often than I need to. But if I left all the implants that I wasn't sure about, I'd have a few that were a mess. So I'd rather avoid that completely. My antibiotic regimen, and again, I'm happy to email us, anyone, just shoot me an email. I'll send you my my ideas. But the idea is basically amoxicillin is our best friend. Clindamycin, they say is the second one for dental. What I've found and studies have shown that clindamycin really doesn't do much of anything for sinus bacteria. It does for oral bacteria, but not for sinus bacteria, so it's rare that I'll use it. I'll also prescribe Flagyl. Flagyl is antifungal, but it just works well on keeping whatever garbage that's in the sinus at bay while things are healing. So it works very, very well. Okay, just to show a case here. Are we doing on time? Okay, we're just over an hour. We're doing great. Okay, so this was a case sent to me that I actually mentored a buddy of mine from a distance. And we measured this case. It was sent to me non-digitally. Whenever you order a CT scan, always ask for the DICOM file, because then we can upload that into Blue Sky Plan and you can see it in every direction. When they give you the printouts or the PDF version of it, you're just really limiting what you can see. So always ask them for the DICOM file. This was a PDF, so I have to measure it on different angles than I normally would. So, and never believe when these labs, these imaging centers will do the measurements for you, because they're measuring just random bone that they don't know nothing about. That's not where I'm putting my implant. So the 6.5 millimeter reading they gave me is totally irrelevant. I need to know where's the trajectory of the implant. That's going to be the number that's important. The 4.6 that they measured is like, if my implant was going to be sideways, great, but I'm hopefully not placing an implant like that. So don't use the 2D for that reason, and you can't see things very clearly. And again, never trust the measurements of the text, because they're not measuring the angles that you need to measure. If you see the tooth here is coming down in this direction, so if I translate that back up to here, I'm more in this direction than I am in the direction that they measured. So don't trust their measurements ever. So 3D and DICOMs, get it back in that file, upload into Blue Sky Plan or whatever software you're using, and you can see it that way. Again, trajectory of adjacent teeth, that's what we're going to be looking for. So the measurements that they gave are totally irrelevant. Okay, so that's just talking about the general procedure of of the crestal sinus lift. So what we're going to do is we're going to drill just shy of the sinus. And when we do that, we're then going to elevate the mucosa layer from the inside. And after that, we're going to place some bone graft and then place our implant. So Blue Sky has a great kit for this. The way I learned this procedure was an osteotome. So the osteotome is you drill shy of the sinus, and this is, if you're working without a CT scan, this is sometimes more helpful. And you're going to up fracture the floor. But what you had to do is if you don't have a CT scan, you're taking an educated guess of how that is, but you can't guess too high. So you have to guess too low. If you guess too high, you perforated the sinus and you're drilling and you're finished. So you have to guess low. And then you're going to guess low, you've got to break that much more bone with a mallet. And let me tell you, that's not fun to be on the receiving end of. It's not particularly fun to be on the giving end of either, unless you feel like hitting people in the head with a mallet. But one of the complications of that procedure is a concussion. And actually, I had a buddy of mine call me a couple of years ago and said, hey, I did a crestal sinus, everything went great. Patient's complaining of dizziness, nausea, and vomiting, and some blurred vision. 2 days later, what's going on? I said, they're concussed. That's classic concussion symptoms. And again, when you have to hit someone in the skull, in the base of the skull with a mallet, that's going to be a potential complication. So, with CTs, you eliminate that to a large extent because you can drill just shy of the sinus. This is Blue Sky's non-guided version of it, which means it has these little stops on each of the drills that are 1 millimeter increments, starting at 6 and going up to, I believe it's 11 or 12. And the drills are also widening in diameter. And as they widen in diameter, they have end cutting or side cutting flutes only, not end cutting. So what they're going to do is we're going to drill shy of the sinus floor. That sinus floor is going to be harder because that's going to be cortical bone. So then what we're going to do is we're going to push with the drill at 1 millimeter increments. If we push and don't push through, then we're going to drill until it goes to the next millimeter. And we go step by step by step until we're through. But again, with CT, it's usually 2 steps and we're there because we drilled just shy of where the sinus was initially. What you'll do then is take the bone carrier, which is on the bottom here. It basically looks like an amalgam carrier. Carry bone up into that opening and place it into the opening. Then these pluggers take the same stoppers that your drills had and puts those, pushes the bone into the sinus. And again, you can push really hard here because you won't be able to push too far because the stopper won't let you. That was also a big complication is you'll start to push bone with an osteotome. It'll get caught up into the very small opening you've made, and you have to push really hard, and then it breaks through, and boom, you're now at the orbital floor. It's not a fun place to be. So they have stoppers on osteotomes now also, which is a huge advantage. I now no longer will use an osteotome that doesn't have a stopper because it's just a risk that I don't need to take. And now you have these pluggers that can plug in and alleviate the need for an osteotome. Osteotomes are great for what they do, but nobody likes doing it. No one likes receiving it. So this is the hammerless kit. You can find it on Blue Sky's website. And they have some videos on there that'll show you how to do it. I'm going to show a video myself of how to do it. But basically what you're doing is making the channel. That channel is now here open. I'm taking bone with a carrier, putting it through that opening, and then the pluggers, and then pushing it all the way through. And what I do is I put in a layer of collagen first. Before I ever put my first bone, I'll take a CollaPlug or any collagen you have, cut up a few small plugs of it and push that up through. Alternatively, I'll use PRF, and I'll use a PRF slug that's has a weight on it that made it dense. Push a few of those in, and now those have started the process of a hydraulic lift on the inside and not a grainy, sandy material. Because again, bone grafting, if you take it between your fingers and press really hard, you're going to feel some sharp edges naturally. We don't want any sharp edges on our very friable sinus graft. So I found this technique to just push collagen up. It works really, really well. And it gets my sinus moving out of the way. Then I can put some bone in to stabilize it more. But studies have been done where people do it just with collagen, and it will work because all I need to do, the way this bone grafting is working, it's a closed system. So it's a highly successful graft because nothing's going to move this graft. We talked a lot about moving grafts and what that can cause to cause it to turn into fibrous tissue rather than osseous tissue. We don't have to worry about it in a sinus because the sinus is a closed system. So we want to push that membrane up and create that blood clot. Once that blood clot's there and I have an implant there at the same time, the implant can actually hold it up and the bone grafting is less necessary. I still use it in most cases because I still like to have more of a secure lift than just collagen and the implant. So I want some bone there also. So I'll do collagen, then some bone, and then my implant. And that's what I'll end up with. And again, I have my sinus floor that I started with. I have my bone is my next layer, and you see your next layer up on top of that is my collagen. And that collagen is a buffer against that thin, very, very thin tissue. And that's the procedure. And again, if you notice that I did 95% complications and what to risk avoid, and only 5% of the procedure, it's because the procedure is not that complicated once you know what not to do. And if you have the tools to make it easier, it just becomes that much easier. And then we're doing guided surgery, makes it that much easier because I can place my guide right on top of the area, drill just short of the sinus with a guide. And now with a guided implant sinus lift kit, I alleviate the need for any of those sleeves. And I'll show you that in a minute. I'll show you a quick video here in the next couple of minutes on just an actual procedure. I'm going to fast forward some scenes just to get through the clip easier, but just to get the idea of what's going on here. Michael, just let me know if this is playing clearly. So far, so good?
Yeah.
Okay, great. Anytime you play a video through PowerPoint, it's always touch and go. So what we're doing here is we're seating, I'm just going to fast forward to some areas. We're seating our guide into place. Our guide is nice and stable. I'll make my first dimple point to make sure that I have the implant going in the right direction. This is not the guided sinus kit. This is just the guided surgery kit. This will work really well also because I'm going to drill just shy of where the sinus floor is. And I've made the stop happen exactly where that sinus is. So I cut through here. We're going next one out is our next wider one. And again, the fear of sinus lifting is always, I'm going to push too hard and into the sinus, but now I can't because this guide won't let me. So it just really simplifies the procedure. I'm going to already at length. Now I'm going to width of a 3.5.
And then it has the plugger is 3.6, so it makes basically.
I'm talking through this, but you don't need that. That's where you could see. There's a pause it here. That little reflection is the Schneiderian membrane all the way at the bottom, and I have my opening right to where I needed to go to. So I've basically done the whole procedure with a guide, and it makes life really, really easy. So now what I still have to do before the guided lift kit was I still needed to now go back to my old kit, as you'll see next, and start to plug the bone in. So this is the first stopper. This opening is the patency on the first one because the opening sizes are a little bit different if you're not using the guided sinus kit. So I'm just opening up that osteotomy a little bit more.
All right, Charles, you're going to feel a couple of knocks here, all right?
Here, because I'm going to show you what this is, a non-stoppered osteotome. And here he had a sloping sinus. So I was open on my mesial, but still the distal, because it's sloping down, the distal was not open. I have my drill through here, but here it's not open enough. So I use an osteotome here just to touch it open. But again, with a guided kit, this is not going to be necessary. And you see it just moves just a hair. That's all I needed. And again, nowadays, I wouldn't even put that in without a stop. And early on, I didn't know how hard was too hard. So when I would push on it, I was usually very, very soft. Here we're putting some PRF into the area. Can't tell actually that's PRF or collagen, but irrelevant. They're pretty much the same here. In terms of physically what they do, biologically they may be a little bit different, but that's a plugger with a stop on it. And I can push as hard as I want because I know that stopper is not going to let it go too far. But as I was saying before, when I was first osteotoming early on, I was too dental because I don't want to bash someone's skull in. So I was really scared to do it. So I had my assistant who had been an assistant for years already. I said, it's not going to be hard enough. I'm like, how hard?
Was that
Hard enough.
cushion
It's hard. It's like, no.
with the bone?
It's like,
Like, is it
give me the mallet.
It creates a blood clot with
Okay.
dissolving.
Gave her the mallet, whack, like way harder than I ever thought, and that was what you needed to do. That was the amount of strength you needed to put into it. So I'm grateful for her, one, for not crushing the patient's skull, two, for teaching me what appropriate amounts of force were going to be needed to do the procedure efficiently with an osteotome. But again, it's a skill you're not really going to need in life anymore. Now that I've placed most of my bone in, I'm coming back with the
I just made it
drill to help
longer
push
than
the bone in further.
what we had.
And
Like it'd be
open it up now to a 4.3. Oop, hang on, sorry about that. Pushing bone. Hang on, we just skipped our implant. Okay, here's our implant
good try, yeah.
going in. That's a max. Just looking at it by eye, I think it's a 4.3 by 10. And I'm going to hand tighten it down here. And again, everything's on the stopper kit. It's going to stop me from at my exact depth that I plan. So again, this makes it so much easier.
No, higher. I put a couple in yesterday at
And we talked a lot about guided surgery before.
I'm getting in the 80s.
I was against doing guided surgery for your first few cases earlier in my career, but now I think it's
right. Well, yeah.
if there's a case you will never have to not do a guided case because they're so easy nowadays and so economical. If you get the right tools in your office, you're putting a healing abutment on.
10.
And suturing.
Do it.
I'll just skip through the suturing. And that's our final case. So we had everything placed exactly how we wanted it, efficiently. This was me taking my time, and it was still about 10 minutes. So it's a great way to go. Just to show you now the updated kit, which I have, because I haven't been in my office for so long, I haven't had a chance to play with yet. I'm gonna blow this up again. There we go. Am I showing the right screen here, Michael? Or am I flipped again?
You're flipped again.
I can't, we're gonna swap presentation. There we go. Okay, good. So this is the brand new guided sinus lift kit. So what this is, and it just made things much easier. You have your drills with the stop that will fit into that same sleeve that I was putting the guided drilling kit into, so that those drills will fit into that sleeve. And the stoppers, instead of having removable sleeves, which I'll tell you are annoying because I've dropped many on the floor and lost them, and they become a big pain in the neck. This Elite just gets rid of those things completely. It also gets rid of the bone carrier, because now we just put it on a small spatula. Instead of going step by step with a bone carrier, like that amalgam carrier, we just carry it. My assistant carries a scoop of bone up to the side, and I take the plugger and just quickly plug everything in very efficiently. So it's just a much smoother kit, easier. Less is more in this case, because we just have less going on. You have a few more drills, but no stops, no removable stops involved anymore. And it's just really an elegant kit. I haven't had a chance to document a case yet, but it's great. So if you're doing guided surgery, definitely go this way. You can also use this non-guided. So you don't have to get, you can have options of both. If you're never going to do that guided surgery, I would still get the regular hammerless kit. If you're going to be doing some guided and some not guided, go with the guided sinus lift kit. And it's just an easier process to go through. This is, we're already running overtime here. This is a short video you can find on Blue Sky's website. I'm not even going to bother going through it here. It just takes you step by step of how this works. Just go to blueskybio.com, go into their instruments. You'll find at the top of the screen, and under instruments, you'll find the sinus kit. And this is their guided sinus kit, sinus lift kit. Is it 4 minutes? All right, let's just, we'll run through it quickly. I'll narrow.
The Blue Sky Bio fully guided crystal sinus kit allows you to safely breach the sinus floor while keeping. Always begin by measuring the preoperative height of bone.
When I do these is I will bring this down. So even though I have a 10 millimeter implant placed, I will only show a 6 millimeter implant here, because the software is going to want to know the end. Where am I going to be drilling to? So I put the end short of where I want the drills to end. Even if the implant then looks like it's sticking out of the bone, I don't care, because I'm going to drive the implant much higher, because once the floor is lifted, I could drive it as high as I want. But I want the end game of where I want the implant to go That's what's going to be important. But again, when we do cases together, I'll be happy to go through that in greater depth. Then we choose our fully guided surgical kit. If you're familiar with Blue Sky Plan, you'll know what I'm doing here. If you're not, do a few cases and you'll get the hang of it pretty quickly. And then put a guide tube into place. Then we have our kit. It goes through the sequences here of the drills, and you just go one drill after the other. And again, it won't let you go too deep, which is the beauty of this. You really don't have to worry about anything else. These are in the profile burrs that are only cutting on the sides. They can't cut the membrane. I go right up to where I'm ending. And what we do here, when you get to your last drill and you add it paper thin, we never want to be spinning the drill as we're going through. So what we'll do is we use it kind of like a mini osteotome, which means I'll open it up to where I want it to be. I'll use a drill to go to my length. And then before I turn on the next drill, which is going to be 1 millimeter higher, I will go into the opening and push hard until I can't push too hard because the guide will stop me. But I push hard and it'll push my way through that last paper thin part of the membrane. And that way you have no chance of perforating this thing. So it's really the safest method possible. And when you do one in your hand, you'll get the concept right away. So when we do in the hands-on workshop, it's really easy, but we can even do this virtually. We'll have a model in your hands. You have to play with this kit in your hands and get a feel for it that way. And then you just go through the motions, lifting it, adding bone in and packing the bone in. And my little trick of adding the collagen or PRF first, I like to do first. They do not have that in the video. And then you'll see that radiograph of how, my most common question I get is, how do I know if I have enough bone placed? So what we do is we take an x-ray and look and say, is that going to be enough for me to get the desired length of implant that I have here? So if we measure this bone to be 6, so now this would mean I've more than double that now, so I'm at 12. So I can get a 10 millimeter implant in there, no problem. That's when I know I have enough. There's nothing wrong with putting a few more packings of bone in there. Too much is not a problem. Too little is a problem. So you want to make sure that there's going to be enough. So the only way to do that without taking an in-between CT, which is unnecessary, just take a PA, you'll see how much lift you have. And you'll also see if you have a perforation, because if you do, you'll see these little particles floating out like what looks like smoke coming out of a chimney. That means you've got a tear and you've got particles floating through. That doesn't mean that your case is lost. It just means you have a small perforation. You've got to manage it in the middle of a procedure. Good, just fast forwarding again. We take our last drill, open to patency as we saw before. And then we go ahead and we place our implant. And that's it. It's really a quick and simple procedure. You will end up spending a lot more time planning the case than you will doing the case. And that's always the beauty of implantology done digitally, is you always want to be planning more than you're doing, because your planning is done well, your doing is efficient and enjoyable for everybody. I'll just go back to my screen here and out of this video. Good. So as we talked about before, we want to start doing an online hands-on course to really, there's only so much you can learn on a quick didactics. You got to feel it. So how do we do that in the age of Corona? So what we came up with is we're going to do an online hands-on course. We're going to have kits and a model shipped to your office. So it means is the kit will be sent to your office from Blue Sky. The model, you'll get the same model that we all get. I'll send you a link to it on eBay or on Amazon. It's the same mold that's out there. It's about anywhere between $30 to $40, something like that. And we'll get out to your office, and then you'll have the model to work with. We can send a guide out that's done in advance of that as well. If we're doing a guided one or do a non-guided one, we can do either way. We're also going to do the first patient case treatment plan together. So you've done a hands-on, that's great. It's still not the real person. And the anatomy of the model that you worked with is going to be very different than the actual human being that you're going to be treating. So we're going to be doing included in that first case to get over the hump of not being face-to-face. We're going to treatment plan that first case together whenever we get back to working. Then we're going to do a live tele-mentorship included in that as well. So we're going to treatment plan it together. We're going to schedule time together while I will be sitting here. you will be in your office. You'll have an assistant holding a video cell phone, just broadcasting what's going on. I will be watching that, and in your ear that you can ask me questions, and I can advise you what you're doing in real time. It's a fabulous concept. I'm really excited to try it out. It would normally be, when I charge for these hand-on courses, is $9.95. What we're going to be doing here is, I talked to Blue Sky about this. They were really excited about the concept. They said for they're a little bit nervous that this is going to go too fast, and they don't have the production right now, because everyone who's producing things is slowed down because they have no employees in their places of business either. So they only have a limited number of kits. They told me they can only give me 10 to do a course like this. So we said we're going to limit this first batch of this to 10. So the first 10 that want to get in on this, will be doing this in the next week or so. What you'll do is you'll go onto Blue Sky Bio, order a kit. It's $1,500, and that will include the cost of the course. So the $1,500 will get you the course itself, as well as the kit. So the course is basically thrown in with the kit at its normal price. And again, we're just limited to first 10 participants who will join in for it, and until we get back to normal, which hopefully be soon. So just shoot me an email when you bought the kit. We'll get that group of 10 together. We'll come up with a time and a date that works for everybody, and we'll do a hands-on course. After that, as soon as we're all back to working, we will do our live courses together as well. And hopefully we'll all get a chance to learn and teach each other and come out of this better and stronger people and doctors. All right. Questions? I don't hear Michael.
Yeah,
There you go.
sorry, there's a long list of questions.
Sorry, we have 50 questions. Okay, so if you're here and you've got nothing to do like me, you're welcome to hang out. If you got to go, that's totally fine. We'll keep recording.
Let me just jump in and just repeat 2 or 3 sentences I said at the beginning regarding the CE credits. If you're watching this live, we'll be sending the CE credits directly to your email. If you're watching the recording, then complete the 10-question multiple choice tests, and we'll be able to send you the CE credit. Check out
Put my email address up here again, so we have it. I'm just going to type it in. Sorry, I didn't have it before.
Check out the schedule of upcoming webinar presentations. Check out the recorded presentations as well. blueskyplan.com/webinars 2020.
Okay, so it's implantnss@gmail.com. Shoot me an email, questions or interest in the course. And if you have interest in the future and not yet on this, just happy to shoot me an email. I'll keep you on the list next time we do the next round. We'll get to that as well. Good. Okay, so Hassan asks, what if use PRF or CGF to close the perforation? Yeah, so I think we addressed that already in the course. Okay, Dr. Camillo asks, when a sinus lift procedure is done, does the sinus have any of its function impaired? So the answer is no. It's a large air pocket that just is open. So nothing's impaired because we saw the drainage is all the way on top. So we're really nowhere near that. And we're really restoring them to the amount of air volume they had in there before. So we're taking out, I mean, nothing. They have about 15 cc's of airspace in there. So we're taking about like, nothing. We do a lateral lift and we're lifting it, putting in, let's say 2 cc's of bone. We're taking away a little bit, but it's of no consequence at all. But good question. Okay. Okay, good. Question. Can you please share at the end of the prescription protocol before and after the sinus lift? Yes. So shoot me an email. I'm happy to send you my pre and post op prescriptions. Okay. Dr. Yuri asks, I got Schneideri membrane damage during the sinus lift surgery and decided to do the surgery again later. How soon can I reattempt surgery? How long does it take for the membrane to heal? Great question. So it's mucosa. The good thing about oral and by extension respiratory mucosa is that it heals pretty fast. It'll be closed in probably about 4 weeks. It'll be closed up completely. I would still give it probably 6 to 8 weeks till I come back in. When I do abandon a procedure, which I do less and less, I would give it probably about 4 to 8 weeks. If it was a lateral lift, it was a big tear, maybe a little bit more. But again, if it's a tiny tear on a crestal lift, 4 to 8 weeks, perfectly fine. Good question. Okay, what is the best medicine you would prescribe for anal antral fistula, for antibiotic and decongestion? Yeah, so both. I would give a decongestion just so that you're letting things stay open and stay patent, because there's irritation from the communication, so you don't want that to cause a secondary inflammation and close off the drainage. So you definitely want to give an anti-congestant. Also, the Medipots, all the lavages that people will shoot in their nose. If they've had chronic sinus issues, they know about it already. But otherwise, what it is basically a small saline, pump. Not even a pump; it's a hand pump that will just push saline up into the nose and get inside the sinus and flush things out. That's the idea, just to keep that passage open. So those are great. Any over-the-counter decongestants work really well also. And the antibiotics, again, I'll send that in an email. We had it up. If you want to review when it's on YouTube tomorrow, go there, or shoot me an email, I'll send it to you. In the photo you showed where there's an oral angial communication, you place a collagen plug first and graft it. Yes. Does the plug dissolve in 24 hours? Is there a risk of bone particle being pushed into the sinus afterwards? So what will happen is it'll be dissolved, not in 24 hours, because it's not open to the oral bacteria. It'll be dissolved more like, I would say, a couple of weeks, maybe a week to 2 weeks, if it's collagen. But what will happen is in the interim, a blood clot will form around it. So what happens is it kind of acts as a sponge. As it dissolves, a blood clot stays in its place. So you always have a barrier in between the two. Good question. If you look through the grafting courses we did before, we go into that in some great depth. But good question. Okay, if I'm prepping the implant osteotomy through the roots, prepping the osteotomy before extraction, okay, is it okay to do a crestal lift before extracting the roots as well, or is it better to remove the roots first? So good question in general. I'm not a huge fan of the drilling through the tooth idea. I know that some people like to do it because it stabilizes the drill. It doesn't let the drill drift. But to me, I'd rather have the roots out and not have a chance of, especially if I'm doing a lift at the same time, not want to push debris of that tooth up into the bone, up into the sinus. Even though it's going to be contained in my graft area, I still don't want to push anything up there. So I'm not a big fan of the procedure in general, but in theory, it would work. So if you're comfortable doing that to begin with, it would work. But I'm not personally a big fan of it. I'd rather nowadays, instead of using the roots to stabilize it, I use a guide to stabilize it. So it gives me a better location, not just where the roots are going, and gets rid of the risk of pushing any material in there. Good. Next question is, during the attempting a crestal sinus lift, the membrane perforates. After how many months to attempt again? Okay, we just answered that. Good question. How to manage a septa during lateral sinus lift. So basically with septa, we talked about it briefly, you treat it as if it's two separate sinuses. The septum cuts down the middle. You have membrane on both sides. There's the bone in the middle, and you've got Schneiderian membrane, it would be my hands, in those two areas. You're still lifting that tissue up on both directions. So you basically treat it like two sinuses. I have never charged for two sinuses for doing that, but essentially it's doing a little bit more work because you have to work around it. But good question. What is the minimum height of bone before placing an implant during a lateral window lift? It's not as much a amount of bone as it is the solidness of the bone. The thickness of the bone will also play into it. So if I put the implant in and it feels snug and tight, then I'm getting, let's say, 20 newtons out of it, then I'm comfortable leaving it alone. What you don't want to happen, I actually left this out of the complications, but I've got a couple of cases where implants get lost in the sinus. Those are no fun. So I always rather, if I'm not really confident, once you close the mucosa, the implant's only got one place to go. If it's going to fail, it's going to go up into the sinus. Hopefully it won't get past the Schneiderian membrane, but once you have one complication, the likelihood of a second complication is higher. So the chance of it getting lost in the sinus is there. I've had it happen 3 times in my career. None of the 3 were fun. So if I'm ever unsure, I would just err on the side of caution, do the graft, and then come back and place the implants. Again, it comes with, you get confidence based on success. So start easy and then ease your way into it as things get as you get better at it, ease into it. But I think my rule of thumb would be, I would say 20 newtons of torque. That makes me feel good about it staying there. And the bone felt dense when I was drilling into it. Soft bone or less than 20, if I don't have both those factors there, I'm going to err on the side of caution. But great question. During one of these cases, while manipulating the membrane bilateral sinus, there was resistance at the point the patient was having pain. Any particular reason? Most likely inadequate anesthesia. So when you do we talked about the innervation. Let me go back to the innervation slide. Okay, so we have the innervation of the sinus here. So you have innervation on the medial wall of the sinus. You inject on the lateral wall. You also give a palatal injection. But if you don't go high up on the palate, you could be good chance you're going to miss some of the innervation there. So always go high up on the palate. I do that for every implant I'm placing, but especially for a sinus lift, especially for a lateral sinus lift. But that would be the reason for it. Okay, what kind of membranes, collagen, pericardium, soft, hard, do you prefer to use? Now, let me pull this over so you guys can see the questions as well. These. Okay, what kind of membranes do you like to use? So my personal favorite is a resorbable collagen membrane that has some stiffness to it. Some of them are very thin. Some of them have a little more thickness to it. I like the thicker ones in the sinuses because I'm asking it to do more than just drape over some graft. I'm asking it to actually contain some graft. So the one I use most commonly is one from Ace Surgical called RCM6. I had a picture of it here. Let's pull it up here for you guys. It's dense, but not too dense. And it just kind of works in my hands. They make a lighter version of it. Here we go. Move the questions out of the way again. That is my go-to membrane in most cases. It's a very durable membrane and works well. Okay. With the amount of graft that I put in, we already addressed that. What percentage of the sinus volume can I fill without compromising its function? Again, once you understand how the sinus works, I think we answered that question by definition. You're on the floor and you've got plenty of room, plenty of air above it. So you literally couldn't put, I take that back. When I was a resident, I was going to say you couldn't put too much. When I was a resident, watching my very first crestal sinus, lateral sinus lift, it was a resident who was being guided by the chief resident. The chief resident, I learned later, did not have that much experience with lateral sinus lifts, clearly didn't understand what he was doing because there was an obvious tear in the sinus because we put in a full CC and the resident doing the procedure said, I feel zero resistance, meaning the full CC went in with no problem at all. He's like, well, put another CC in. Put another CC in, no resistance. There's no way you lifted that much tissue to not have any resistance. So what they had is a huge perforation. Instead of saying, you know what, maybe we have a perforation, let's evacuate that out. He said, let's put another CC in. And hey, that's not good enough yet. Let's put another CC in. Guess what? The patient came back 2 days later with a massive sinus infection. But again, you learn more from failures than you do from successes. So what I learned is you need resistance when you're doing a lateral lift pretty quickly. Within the first CC for sure, you're feeling some resistance and you're packing it in gently. So you can put too much, but only because it's not contained. Once it's contained, because you did an appropriate lift, then it's not going to be too much, and you could put in 1 to 2 cc's is plenty in the overwhelming majority of cases. But again, in crestal lifts and not in lateral lifts, you're usually putting maybe half a cc. So it's very little to begin with, and the way you know enough, as we said before, was take an X-ray. A good question. Okay, during surgery planning, how can I calculate the graft volume I need? So again, it's just you can't calculate it exactly because it's going to dissipate based on if some sinuses are very narrow at the floor, here's the floor, and I'm very narrow. Some sinuses are very wide at the base. So to get the same kind of lift, if it's narrow, I don't need a lot because it's going to push straight up. If it's very wide, I need a lot more to fill up the floor until I get enough height. So by knowing if you have a wide floor versus a narrow floor, you'll know how much you need to lift. You'll have a better idea if you need more or less. But The only way to really know is to take an x-ray and see how much vertical height you have. And just to show that picture again, let me scroll down. As we showed here, once you have a lift that you can look and say, okay, my implant can fit in that space, that's when I know it's enough. Good. And getting these x-rays is not easy either. This is not a great x-ray because I can't see everything, but it's enough that I told my assistant, don't bother taking another one. You got to get really high when you're taking these x-rays. Don't take it as you're taking a PA, because you're not looking at the periapical areas. You're looking much more superior to that. So the palate won't allow the sensor to get much higher. So you've got to angle things quite a bit to be able to get in there. So oftentimes the patient's wearing glasses, they have to remove their glasses because you're resting on the orbit to be able to get an angle high enough to see the lift of the sinus here. That's another important point that we'll talk to your assistant about when we're training them about what to do here. Okay, how can I calculate the amount of graft material needed to fill up the space? We just talked about that also. Any hints or tricks when doing internal lift in ascending medial wall of the sinus and the apex is not parallel to the floor? As we talked about here, I think you asked this question before I got to it. When you have a slope here, that's the only time I still pick up an osteotome. But with this kit, the newest guided kit, you don't even need that because the last few pluggers will serve as that osteotome. Basically, you drill only until a sloping wall here, or let's say here, the sloping wall down here. I'm only drilling to the shallowest point, because if I drill higher, that part of the drill will be through the membrane when the other part of the drill hasn't got to the bone yet. So I go to the shallowest point, then I'll take something, either an osteotome or in a guided kit, just something to stop on it and push hard and up fracture that last piece of bone. That's your trick of how to do it. Just aim shy and push up otherwise. So if you have a guide, it's easy. If you have an osteotome, I would highly suggest in those cases to make sure to use a stopper. And you can get stopper kits, stopper osteotome kits on eBay pretty inexpensively as well. If you're don't have access to to guide materials or to the Blue Sky kit, or you've been doing this for a while and you use osteotomes and you want to just upgrade your osteotomes, then get one with a stopper. It makes your life so much easier. Okay, if there's an existing polyp in the sinus when you are placing an implant during a crestal lift, is it okay just to lift the membrane and or graft? And graft, does the polyp need to be referred to be removed first? So it depends on the polyp we're talking about. If the polyp is something dangerous, then obviously yes. If the polyp is something that's full of bacteria, then also yes. That's, again, diagnosis of the sinuses early is going to be important. If you're not sure, you're welcome to send me an email. Or again, it's a good idea if you're to find someone locally, an ENT to work with locally, so that when you have cases that you need to refer to remove things, to already have a rapport with them and say, hey, can I send you a couple of scans? And then the ones that you need to treat them, I'll refer to you, and that way you build a mutually beneficial relationship and you get to learn a lot more about sinuses. Does lateral window size influence post-surgery epithelial migration in the grafted area? So yes and no. You don't want to make a massive hole. You want to be able to have something that's going to close up relatively well. And the bigger the opening is, the longer it'll take to close. I'm going to put a collagen membrane on the outside when I close anyway, but I don't want to make a hole too small that I can't get into well. So you want to make an in-between sized opening. And in-between is a very subjective term because I don't know exactly how big it is till you're comfortable to see. I like to make it big enough that my instruments can go in and out easily without bumping into walls around it. So I would say that, but I can't give you a specific measurement. If you send me a case and you show me what your instruments look like, I'll give you what I would be comfortable with. But if you're doing laterals, then I would say don't go crazy just to make them so big, just to have extra visualization, because it doesn't really help you that much. But don't make it so small that you have no visualization either. Okay, what is your opinion regarding mixing antibiotic solutions, the bone graft? I talked about that in the bone grafting lectures before. I'm personally not a fan of it. But not because there's anything wrong with it, just because I've never done it. But again, it works. Can you please email copies of the slides? So it'll be on YouTube. Can you please repeat what to do in a case of perforation occurs? Just put collagen membrane or graft the socket. So again, we said before, if it's 2 millimeters or less, you can just leave it. It should spontaneously resorb, but I still like to put collagen in. And they have to have sinus precautions not to put extra pressure on it. If it's 3 millimeters or more, you need to close that up physically, which means you have to extend the flap, which we talked about in the grafting lectures, how to release a flap, pull it over the socket and suture it shut. In that case, if you're worried about an implant later, I would also suggest putting a membrane so that once you're getting a primary closure over a socket, we talked about in great length before, that could counterintuitively negatively affect your socket unless you put a membrane in there. But get into the long answer if you review some of those lectures. Okay, instead of sinus lift kit, it can be some sort of SG. Dr. Lev asks. I'm not sure what SG stands for. So you'll have to repeat the question and just clarify that. Dr. Kakmak asks, is there any case especially you prefer to use mineralized bone graft or always cortical cancellous? Again, go back to those older lectures we talked about at length, but the short answer is mineralized bone will show up in an x-ray, demineralized bone won't. How much collagen do you place? Dr. Lichter, what's up? Just enough, if that makes sense. It depends. If it's a small socket, I want to fill up that, let's say, half of the socket with collagen. So it's not a lot. You're talking about a piece of a collar plug. It's not much. Or if you're talking about when you're lifting, I'm also taking, let's say, I'll take a full collar plug, I'll cut it into like 2 or 3 pieces, and I'll put the whole thing in there. The more, the better. So there's no downside to it. Can you do small pieces of membrane instead? I've noticed collar plug gives some resistance when packing. You want the resistance when packing. That's the whole point. The resistance means you're lifting the sinus membrane. So you want that. You don't want to push too hard. So you need to stop to not let you push too hard, but you want that resistance. That means it's doing its job. Great question, Dr. Ariel Forbes. Great question. But yes, don't use membrane. That's not helping you. Collagen is much less expensive, and you're going to get much better result. Dr. Stephen Reed asks, when you use ethos, come in a syringe, much easier to use, and not as granular. So I was talking, I guess this is big in Europe now. I got sent some slides of this ethos. It basically looks like a plaster of Paris with bone graft material inside of it. And it just kind of creates like a bone cement. You have to work fast with it. So I've never used it myself, but it looks like it's going to be something that's going to set pretty fast. So I'd be careful to use it here because you're going to be packing it into this opening. It's going to set on you, and now you're going to just blocked up your opening to place more graft. So I don't think it's a good material for a situation like this, for a crestal sinus lift. Lateral maybe, but crestal not. And again, I don't even like the idea of something very hard as a lateral, because something very hard to me is just going to give me big clumps that can break off and cause a blockage of the OCM. So OMC rather. So no, I wouldn't use it myself. I don't think it's a good idea. Here's another question about sloping floors. We talked about that. Is there a perf in the vertical lift? You place collagen first and then graft, will it heal? Depends how big the perforation is. And it's hard to tell because we're working on a blind procedure here. So what I do is I first place the collagen, and I can't tell if I've perfed yet. I hope I haven't, and I generally haven't, but I can't tell for sure. So I place the collagen first, then I'll place some bone. And even if there's a perf, what that collagen is going to do, or PRF is going to do, is going to contain it. So if my collagen spread more than my perf did, it's going to give me a artificial seal of the membrane and allow everything to proceed normally. So it could be that I had a perf and I never knew about it, and that's fine as long as I never find out about it later either, which means everything healed well. So yes, I would say if you see a perf, like meaning you drill in or you osteotome too hard and you can see it's in, or the patient's breathing, you see air going in and out, and you haven't lifted at all, that's a big problem, because now if you put collagen in, it's just going to go straight up into the sinus cavity and just get lost in there. Collagen is no problem because it's a small piece and they'll dissolve very quickly. The graft material is going to be important to be using small particles so that it can easily still get in and out of the OCM OMC, keep saying that backwards. So that way, again, just use small particles, place a little bit in the beginning and take an x-ray. If you see it's not staying towards the floor, but it's just a chimney, you've got a perf and a bort. If you know what you're doing, you can open a lateral window, lift the whole sinus, put a collagen membrane to seal it, and then proceed. But again, it's not for the light of heart. Dr. Forbes asks, can a guided sinus kit be used with any implant system? Yes, that's really important. It can be used with any implant system. The drill up till a final drill is the same. You're just opening an opening to the sinus. Then you switch over to your sinus kit of the implant kit of your choice. Use the final drill that you would use, which I generally would suggest to under prepare these, because this, again, the bone is very soft and you want to get as much primary torque here as you can. So if you're placing, let's say, a 4-3 implant, only drills with a 3-5, 3-6, and then place your implant that way. But yes, it can be used with any implant system, and that's one of the beauties of it. Dr. Alam asks, what would you do if there were complications, concussion-like symptoms after using a mallet? Not hit that hard again. But concussions, there's not really much treatment. It's just wait it out. But it's, we know from now contact sports that those can be damaging and have a cumulative effect over the course of time. If someone has a minor concussion one time, it's not a big deal. But there's no way to put a number on what's too big a concussion and what's not. You're not going to cause a massive concussion here. It's going to be a small concussion. But again, the less you have to drill, the less you have to mallet, because you drilled appropriately close to the sinus, it's not going to happen. So if you have a CT scan, it really shouldn't happen. Well, if they complain of vertigo, same thing. I think that's concussion symptoms. If you're using PRF, you soak the material with PRF mix or pieces of cut up PRF. So you can go either way. Everyone has got different styles of how they like to use PRF. And get into a separate PRF lecture. But for these, the most important part of the PRF is that initial couple of slugs that I'm pushing in. I'll put the weight on top of it to make it a little more dense, because I want it to have some push to it. And those are the most important pieces. After that, the graft is really secondary. You could totally skip the graft, just use PRF, just use collagen, and you will still get a good result. I just find it to be a better result with some bone particles to help hold it up for longer. Okay, then we have, how do you know how much bone volume to place? We talked about that. Can you talk more about combining the hammerless kit with the fully guided kit for these cases? So I think I got into it. Hopefully you still saw that before we finished that part. I think we talked about that at length already. If you have any further questions on it, happy to shoot me an email and we can talk further. Would you always place a healing abutment rather than a cover screw? Great question. I should have mentioned that before. I would say I'm much more gun shy today than I was in the past. I don't love putting healing abutments on implants in general, for two reasons. One is I'm introducing additional movement to it, which is the lesser concern. The bigger concern is I'm allowing bacteria to get closer to the bone during early healing that I don't want. We talked about this at great length in the last lecture. So look back on the question answer session. We talked about that a lot in detail. What I do nowadays, I'll just say briefly, is the 1.5 stage procedure. I place the implant, I take a digital impression of that implant, and when I go back to uncover, I already have either final crown or a temporary crown to seat down into that implant. So it's a custom healing abutment with a tooth on it, basically, which is the ideal shape of the tissue. I save the visit for the patient, so they don't have to have extra visits involved. The only downside is if they get numb in extra time, but the upside is tremendous in terms of bone stability. But that was discussed in the implant lectures we talked about before. And again, shoot me an email, happy to discuss with you later. Are these available in Europe now? I tried to buy one and they were being released and couldn't get an order to take the hammerless kit. So right now, I'm not 100% sure. If you can't get it, shoot me an email and let me know, and I will call Blue Sky and see what we could do to get it out to you in Europe. Just because with the COVID situation and shipping things in different areas of the world may be slowed down significantly. But give it a try. If you're having trouble, get in touch with me and I'll forward it over to Blue Sky and let them know. In the site, I can only see the old kit. Link to the new one. Okay. So I think what's happening is if you're clicking from Europe, there's some different features that are not available in Europe yet. I think it has to do with FDA versus CE stuff. So to see what's there, click on it from the United States, like as if you're checking from the United States to see what's there, and then just shoot them a separate email and say, hey, I'm in this country. Can I get it, this product sent here somehow, and see what they could do for you. Okay, I'm speaking about the original non-guided hammerless kit and traditional implant guide. Dr. Kaleni asks, I'm not sure what the first question was. So just, Dr. Kaleni, repeat that question in its entirety and I'll hopefully get to it. Also, the kids go up to about 3.5. I'm sure what kids you're talking about. What do you want if you're placing a larger implant, like a 4.7, 4.8? Yeah, the wider diameter, the better. If you have the width for it, the wider the better. But I'm not sure the total question there. So repeat it if you can. How frequent is the membrane would perforate under pressure of a graft? Very infrequent. If it's done properly, most tears happen during the opening, not during the lifting. So if you haven't perfed during the opening, you're probably going to be fine during the lifting. Just got a quick drink. Okay. How do you manage perfs during crestal lifts? So you abort, do you proceed? Does it depend on the size of the perf? I think we just talked about that. Collagen first, then bone graft, a little bit of bone graft, like your first couple of pushes through, and then take an x-ray. And again, if I'm seeing a smokestack that there's nothing being contained, that's when I'll abort or do a lateral lift. But otherwise, let it close back up and come back. And in that next case, what I would do is wouldn't drill quite as close as I did the previous time because you probably drilled them too deep. That's the most common cause of it. Again, I've been doing this a long time and I've done a lot of them. So perfs are very infrequent. The most common thing that we're perfing is my sinus floor is here, my drill is going here, and I made my drill go a little too deep. And that's what happened. If I drill just shy of it, and now I take my next osteotome, or in the guided kit, I'm taking the next plugger that's going to go up. Again, I drilled to here. Before turning the drill back on, I'm going to push. So I have the most that can be is less than 1 millimeter, and I'll push it through. And they'll generally, that's how I know I've pushed through and I haven't broken anything. I haven't torn anything. That's the safest way to do it. But if you drill all the way through, that's when you're going to get yourself into trouble most of the time. So the best way to manage a perf is to avoid it altogether, obviously, but that's the best way to do it. If you have a CT and can drill just short of it, that's your easiest way to do it efficiently and with very minimum chance of perfing. You said too little graft material is bad. Is it really so bad? I saw studies that shows pushing the sinus floor by 2 to 3 millimeters up to 6 millimeters out of the graft produces bone by itself. Yeah, we talked about that, Dr. Kirali. We talked about that you could do this without any bone grafting at all. The implant itself can hold up the lifted membrane. You just have to lift it. If you look back on, I'm sure you could find it on YouTube, they used to have these systems where you would put like a little balloon into the sinus, and with saline, it would disperse evenly and push the sinus up that way. So if the sinus is very well lifted, and then you put implants and no graft at all, you just have it filling up with venous blood that's just in the area, you'll still get bone to heal because it's a closed space, same as a socket. You open a socket up, if it's a closed area, bone will fill in, right? There were years before we did bone grafting, and people didn't walk around with craters in their mouths. Bone filled in because bone will close up the area. Grafting just helps it do better, but without a graft, it'll still work. So you don't need to put bone in, it's just helpful. Can you explain step-by-step drill sinus elevation procedure? I don't know if that question was asked before or after I showed that video, but you can go back and review what I showed in the video and review on Blue Sky's site. They've got a step-by-step drill procedure that you can see clearly there. Is the last done drill without irrigation? Good question, because I don't want to push out the bone that I just pushed in. And if I have full irrigation in that last drill when I'm opening the patency, so what he's asking is, I've already lifted, everything's set. Now I'm drilling my last implant drill, so put the implant into. Do I turn off the irrigation there? Because I'm going to irrigate, it's going to push water into the sinus, hypothetically, and flush some of it away. So the short answer is you're not going to flush a lot of it away. Usually whatever you flush away is the extraneous graft that just kind of like didn't make it into the opening. You'll see like there's some shavings around the outside. But again, you're working with soft bone. If you turn down the speed of the drill, you're not going to create a lot of heat, and you can turn off the water that way. So whatever you feel more comfortable with will both work. What I like to do is, if the bone is soft, I will turn the drill into reverse and put my last drill that way. So what that does is two things. When the drill's going backwards, it's now, instead of drilling out bone, it's pushing up bone. So any of the extra shavings of bone, that loose particles, are going to be pushed up further. And also, instead of cutting the walls, it is compressing the walls. And in dense bone, I don't want to do that because I don't want to overly compress those already dense walls. But in soft bone, that's very advantageous because now I'm making that bone a little bit stronger than it was before. So that's a nice little tip. Last drill, assuming the bone is soft, turn your drill in reverse, turn the water off, and turn your speed down and drill up that way. Nice little tip that I find very helpful. Is the last drill done without, I just read that. Can we get these in Europe? Hopefully. But again, if you don't, please shoot me an email and I will, or to, I don't think Michael deals with that stuff, but I'll forward it over to Blue Sky and get it, find out how we can get it to you. Will the recording be available? Yes, it will. When you're faced with a sinus floor that has a significant vertical slope, how do you approach the ridge? Okay, we talked about that, but really important point, and that's part of treatment planning, but excellent question that we talked about already. What do you do with tearing membranes during the crestal lift? We talked about that. Try and avoid it. How do you decide how much elevation? We talked about that. We have 4 millimeters of or more of sinus floor and need to insert 2 or 3 implants. Can we do in a closed sinus lift? Yes. And does each implant need its own lifting? Yeah. So that's one of the times where I'll still sometimes, for just efficiency, do a lateral lift. Because if I'm doing, let's say, and this is before guided, truth is, because with guided, it doesn't really make a difference. Let's say I got to put 3 implants into a quadrant. If I do the crestal lift, I have to do each lift separately. If I do a lateral lift, I'm doing 1 lift and placing 3 implants. But with a guide, again, I'm putting everything exactly where it needs to go. I'm lifting exactly where those implants need to go. And with a guide, I can do that drilling sequence very quickly. So I would say you would need its own lift for each one, but the guide, it's done very quickly. But that might be a reason to still do a lateral lift if you're not using a guide. Okay, Dr. Singh asked if it's not immediate placement, how long do you typically wait after a sinus lift before placement? So I don't know that there's a time I would do a crestal lift and not do an immediate placement. If it's so thin that I couldn't do immediate placement, I was probably doing a lateral lift anyway. The only time it would maybe happen is if you, let's say, spun out an implant that you put in too big an implant, and you open it up too much, you drilled too much, and now you go to put in that implant you planned and it's spinning, and the next size up is spinning, and now you just don't have any walls left. And if you do it again, you're going to end up causing a big mess. That's when you would not do an immediate placement. Then I just put graft in there, wait, same as I wait for any graft, about 4 to 5 months, let's say in the posterior maxilla for a sinus graft. Take an x-ray, just see that it looks like it's firming up, and then go forward then. But good question. What are instructions given to patient after sinus lift procedure? Shoot me an email, I'll send you it, or just review the slides tomorrow on YouTube and you'll see it there. How do you handle sinus perforation during crestal lifts? Talked about that. Dr. White asked, CTs are now revealing many residual apical lesions over endoteeth. Yeah, tell me about it. They are asymptomatic. Many feel that is an inflammatory response. I see these often and just don't have an answer. Opinion. Great question for implants. I think we talked about it in the implant part of the lecture. I just want to get too off topic. Look back at those previous lectures that I gave, or shoot me an email and we can discuss further. But excellent question, really important point with treatment planning. What do you do if a tear happens during internal sinus lift? We talked about. Dr. Khan, is guided sinus lift more reliable and compared to other techniques? How much more time does it take compared to others? So yes, totally reliable and much faster. So it's faster, more accurate, less chance of complications, like only pluses here. The only downside I could imagine is that it takes time to plan it. But that's a plus. If it doesn't take you too much time, just takes you an adequate amount of time, I find that to be a plus as well. And again, the first couple of cases will take you longer. To get used to doing anything differently is going to take you longer, but it's well worth the investment because this is such a common procedure in the implant world that if you're doing a fair share of implants, you're going to be doing this 25 times a year. So yeah, definitely worth investing in doing guides to make it faster, easier, better, and not want to do it because it takes you too long because you put in the time and you learn how to do it well. What if after crestal sinus lifts and after grafting, we see some materials in sinus RTG? Do you have to remove all materials? On RTG, I don't know what an RTG is. If you could clarify that for me. Just ask that again. Dr. Lee asks, patient had an implant placed about 4 months ago with a crestal sinus lift. Patient has a sinus infection that comes and goes, but the implant stability is good. What should we do? Sinus infection where? In the same area? Implant is stable. Is the sinus infection has nothing to do with the implant? Could be it has something to do with it. Could be it doesn't. If they had previous sinus issues, meaning they could be unrelated, but they could be related. So you should definitely find that out. And when you say the implant stability is good, if the implant is healed, generally it means it's something not to do with the implant. That again, we've lifted the tissue, and it's a whole environment inside the tissue, and we're trying to avoid that environment completely. So if you put the implant in, everything healed, and your implant's solid, and they still have something going on in the sinus, it's likely that they're uninvolved. But I have to see the specifics of that case to know for sure. Do you think it's okay to use a collagen fleece? I don't know what that is. Just send me an email what that is, and I'd like to see what that is. Once the lift has failed, i.e. infection, would you remove filler material, flush with sterile saline, possibly mixed with tetracycline, and close and return 4 to 6 months later? Yes, I would do all those things, except for the tetracycline, just because I don't like shooting tetracycline in where I'm not sure where it's going. But yeah, everything else is fine. But the idea is you have to create an opening for everything to drain out. So I would take out the implant, and if it's a true infection around that implant, you're going to have pus pour out of there quickly. If you saw that earlier case, just bring that back up here, where I had that crestal infection that went wrong. Yeah, this guy, you take that out, generally that's going to shoot out a bunch of fluid, and you want to leave it open. Don't create a tight seal around that. When you stitch it back up, put some relatively loose stitches so that when there's enough pressure, it's going to still push its way out for a day or so. And then anti-inflammatories, antibiotics should take care of the rest. You may even want to leave a drain in there for like a day and let them come back at 24 hours later and then stitch it up then. That's like as if you would be doing an incision and drainage. That might be an option also. Dr. Garibay asks, what type of bone does the graft become after SBG has healed? I'm not sure the SBG is, but basically you're asking about what does grafted bone turn into? Is there no periimplantitis related documented in the long term? So again, periimplantitis is coming from the crest of the bone, and then the grafted bone here is at the apex. So they're two different spots completely. So if your periodontal bacteria has reached so deep that it's reached the crestal bone, we've got a bigger problem. If you look into the last course I gave on implant surgery, we talked a lot about what we can do nowadays to keep the crest of the bone at or above the platform of the implant. So take a look there. Really important implant information there. Would you recommend always using guide sleeves with your guided case? Are you happy doing without? Personally prefer always. I agree with you. Metal to drill against titanium rather than to drill against resin is always a better idea because you can cause friction and shavings of the guide to get lost in areas. To me, it's just a cleaner procedure with a sleeve, and it's a couple of bucks. Like I even reuse the sleeves when I'll place a sleeve once. I think they're like $5 for 5, so it's like literally $1 per sleeve. Like you could throw them out, but what I'll do is I'll use the guide. If it's not damaged and it pops right out, I'll sterilize it like I do anything else that I put in someone's mouth, and I'll happy to reuse it. How would you manage intercrestal bone leaking into the sinus? Intercrestal bone leaking into the sinus after taking your X-ray. Not sure what the question is. I think if you're talking about the grafted bone, not the intercrestal bone. The grafted bone leaking into the sinus, meaning if you have that smokestack showing, then either if you have a total perf that all the bone is lost, then just flush whatever you can out, but you're not going to get much because it's such a small opening, but you've used small particles, so things should be able to flush their way out of the cilia will push everything out itself. So try and suction out and flush whatever you can, but don't go crazy and stick lots of things in there because you make it worse. I have a small tear happens in an internal lift. Do you still place the implant, graft, or abort? Again, it's a case-by-case basis. If 90% of my graft is there and I see a few particles floating above, I'll still place it. But if it's most of the graft is lost, abort. Can you explain drilling diameter step by step? Look at the video. I just skimmed through it quickly for time's sake. So look at the video, and if you still have questions, feel free to shoot me an email. You can alter the set rate depending on amount of water added. You can alter the set rate depending. I think you're talking about that like plaster material. But again, I don't like the idea of one big glob of anything in the sinus, because if it detaches, I got a big problem. Is it possible that the sinus membrane would have less resistance than adherence it has to the bone? So instead of lifting it, you perforate it when you push on it. So no, mucosa will lift off. It's mucosa on one side and periosteum on the other. So you're actually pushing against periosteum. So it's a little bit tougher, the side that you're pushing on, because you're coming from the bone, the inside the bone area. So, but you still want to do it on a broad base. You don't want to use a fine point to push on it because you'll perforate it, right? Because you'll have more pressure into that. Pressure is force over area. So the smaller area you have, the same force, it's going to cause a perforation. You want it to be a wider diameter and then push up on it. So it will lift. Dr. Lem, thank you for your lecture. My pleasure. I just had a question about antibiotic regimens. Do you modify dosage when there's a chronic infection? So again, it depends. If they've had a chronic infection and I've been in touch with their ENT before, we'll go based off of what they've been successful with before. That's a big help. If they have chronic sinus issues, definitely be in touch with their ENT before you start. And they already have a history with this patient of what works for them based on what their situation is, what pathogens they have in their sinus, and what's working on it. So I would leave it based on the past, what they've had. Dr. Gelman, hey, what's up, Asher? Any implant thread design or apex design that contraindicated or too aggressive or sharp that you would avoid? Great question. I used to make a big deal about it and thought it was a really big deal. Until now that I'm putting collagen as a buffer, it doesn't really matter. When it was just the implant pushing right up against the thin membrane, then yeah, you'd want a domed shaped implant apex. And that's what I used primarily for those. The Blue Sky had the Trilobe design, which was a great implant for its era. Nowadays, the platform is not nearly as good as the Max implant or the Conus implant, but that would make a big deal if I'm pushing right up against it. But now when I have collagen in between, and which would then turn into a blood clot a few days later, I don't think and you see when things heal, it doesn't heal where the bone is right up against the top of the implant. There's usually a buffer of the graft material in place, and that would be a difference of putting graft material versus just putting PRF or collagen. So the collagen works the day of placement. The bone graft material acts as a separator between everything else in the healing process, and then I would say the design does not matter at that point. And I use the Max implants as my go-to implant, and it works great. A good question. I like the questions when you're thinking. I feel like I'm getting the point across when you're asking good thinking questions. That means that your own questions will be answered as you're doing these because your mind is working in the right direction. So thank you. When you push, Dr. Lee asks, when you push with the last one, do you detach it from the handpiece or do you hold it in your hand? No, never detach it in the handpiece, because the stop, you get much more control holding onto a handpiece. So with the handpiece in your hand, before you spin it, and that last drill sequence he's asking, before I turn it on, always push up. And that way you'll do it, but no need to take it out of the handpiece. Can you please speak a little bit about the transition from sinus kit to transitional implant kit regarding the final length? Yes, so just again, imagine length doesn't matter when that's, if you're a Michael Scott fan, that's funny, but, and my 14-year-old son is laughing in the background. Length doesn't matter when you're dealing with sinuses, because once you have it lifted, if you can place the implant as far as you have lifted. So once you lift the graft, the length doesn't matter. So you're only drilling to the floor of the sinus, lifting the rest. So I drill here and I lift till here. I can place the implant all the way up till here. So it doesn't really matter. Hope that makes sense. Dr. Sherwood asks, is fabricating a guide for a lateral sinus lift a useful possibility? Yes, I've seen it done. I've never done it myself, but it definitely makes creating the outlines for it well. I've seen, who have I seen post it on some Facebook groups? Implants in Black and White, great Facebook group. They've shown some cases there of doing printing for lateral lifts. It's a nice idea because once you're already printing it, you can print it with a higher flange and a window for it. But to me, I just have to make the flap that much bigger. So I've never done one myself, but it's a nice idea. Okay. Good. In type 4 bone, how do you feel prepping up to 4.3 and self-expanding with a 5.0? I love it. Do it. It's a good idea because you want as much stability as you can in the posterior maxilla. What RPMs do you turn your drill down to for fast one drill backwards? So I'll turn it down. When I'm generally drilling, I'm at 2000 RPM, and I talked a lot about this in the previous class. I want the drill working as fast as efficient as it can. When I turn it down, I'm turning it usually to about 800. I know a lot of people, that sounds like a lot still. If you feel more comfortable, you could turn to 5, but 800, and it's a short burst. I'm just quickly going in one time, and that's the end of it. So I'm not really producing much heat, and I don't think it's going to be an issue. Okay. No sinus issues before. Patient claimed to have symptoms after the implant placement. I think you were talking back about that sinus issue before. So send me some x-rays and a brief history of the patient, if they've any sinus conditions they've had, if you have a pre-op CT, helpful. Send me as much information about that specific case as you can, and I'll be glad to help you out. Another question about the ethos, less water. Yeah, again, ethos I think is a bad idea in the sinus. If there's not metal sleeve for, and I'm sure someone from Ethos is watching this, I apologize for I've never used your product, but I'm just speaking on big particles. I don't like anything that can clump into a big particle that we could get trapped in the sinus. I don't like the idea of that being used there. If there's not a metal sleeve for a guided care, we worried about resin. Yeah, so I like using metal sleeves for my guides. Collagen fleece commonly used in old lateral window technique. It's thicker collagen membrane that is like a foam-like membrane. So like a mattress. That sounds like a good material. Is it a collagen membrane, or is it just a collagen plug? Meaning, is it dissolving in 6 months or dissolving in 2 weeks? That'll be my next question. But if it's the thicker it is, again, it's just a preference. When you put it in, if I'm pushing it over a perforation in the wall, in the sinus tissue, then it's a good idea to use something thicker because I want more support. Where can I find the kit with a course combo? So Jason's asking this question. So Jason, nothing is listed there. I just spoke to the company today about doing this. That's when they offered to put the kit and the course together. So just order the kit and shoot me an email that you're interested in the course, and we'll set it up when we have that group. I can't find 10 MCQ for the CM. Dr. Hussein, I don't know what that means. So please just clarify what those abbreviations are. May you please direct me. Again, I'm not sure what the 10 MCQ and for the CM means. So just clarify that. What particle size do you recommend for the graft? So graft particle size is 250 to 1,000 micrometers. So the small particle graft. Generally, most companies will make a 250 to 1,000 and 1,000 to 2,000. So use the smaller one. Will you always place a handpiece or with a torque wrench? Personally, I prefer handpiece, feel more and feedback. Okay, so I've gone through different iterations in my career of ratchet wrench versus to torque it, a torque wrench to place the implants versus handpiece. I now do a hybrid, and it kind of goes case by case. In that case, you saw the video, I have to use a torque wrench, but you could just as well use a handpiece. Any thought on throat drilling protocols in these cases? Yeah, again, in soft bone, slow drilling is fine. You don't need it to go as fast because the bone is not as strong. Dr. Reed says dissolves in 2 to 3 months. I think that's the fleece, the collagen fleece we're talking about. So that's like an in-between. The one I use is 6 months. I'd rather something more, a little bit longer lasting, but that could work. In theory, it could work. I just haven't seen it. I never like to be the first guy to use anything because I'd rather see someone else fail and learn from that before I use it and fail. So I'd always like to see someone else using it, have success with it before doing it myself. But sometimes that's not possible because it's something brand new and you're trying it out for the first time. So whenever I can, I'll try and watch somebody else first, see a paper on it, see some long-term studies on it, even just enough case reports that I know it's being used successfully. And then the not as obvious pitfalls in something will be tested out by somebody else. I don't have to be the fall guy for something brand new. Don't use them anymore. Always PRF plugs first. I agree. PRF plugs is I think the gold standard for more of the microbiology reasons than even the usefulness of it, because it still takes a blood draw and it takes a little bit more time to get to it. A cowl plug for me is still easier, but I still like PRF more. It's worth the extra effort, I feel. But if you don't have it in your office, when I go through the courses, I'll go through like bells and whistles of implants. And we go through like what you should be spending your money on and when. So if you have unlimited funds, that's great. And we'll say buy everything. But most people want to prioritize. Okay, I'm going to get this now. And then as I get more cases, then I'm going to get this next and this next. And what I see a lot of times is companies will push you to get nonsense. Like if you're a seasoned veteran and this makes your life for an implant can save you 4 minutes on a case and you're doing them all day long. Okay, so that's an item worth purchasing, even if it's for several $1,000s. But if you're doing a couple of implants a week and saving 4 minutes a case is nothing to you, then don't bother. So I always want to temper your excitement to get into implants with using what's going to be most useful to you, not just spend money anywhere. Okay. So PRF machines are great, but it's a little bit further down the list in terms of uses, unless you really like it. If it excites you and you're into the science and technology of it, then go ahead. It's not a terribly expensive contraption. Dr. Reed says, use PRP over the wound, then Blue M gel. Do you have USA Blue gel? Releases oxygen over the wound. I'm not sure what it is. So if you could shoot me a link for that, it'd be great. Compatibility of kit with other implants. We talked about that. Fully compatible with any implant kit, because you're still going to use your final drills from any other implant kit that you've been using. How to line a tire roof with collagen since drill hole is smaller? I'll only line the roof with collagen in a lateral technique, and with the lateral technique, what I'll do is I kind of fold the membrane up, push it into the window, and then it unfold it into when it's in the sinus. So that is that. Okay, and that is all of our 98 questions. Hey, everybody, if there's any others, throw them in quick. We are 2.5 hours in. I tried for an hour.
Right, so I think next time you have to hit the X on the top of the question after you answer the question, then the number will start going down.
Good. All right.
That's very
But it's been
impressive.
fun. Thank you guys. So shoot me an email. We did last time is if there's like more topics you want to get into greater depth, I'm happy to do small groups. We did a few of them already, more face-to-face on Zoom. So if there's any other topics you want to get into, shoot me an email. Happy to do it.
Yeah, and I definitely recommend following up on the in-plant remote coaching program. And again, Dr. Mickley's offering the first dentist to send the first case. He's offering to doing the coaching at no charge, and hopefully we'll broadcast that as an educational tool for everybody else as well.
I feel like CNN would pick that up as like the first dental implant place after COVID. I feel like that would be all over the implant websites everywhere.
Yeah, that would
Big
definitely
celebration.
definitely newsworthy.
Confetti drops from the roof. That's obviously been sterilized and COVID free.
Okay, and we're continuing with the webinar series and offering additional educational opportunities. So stay tuned, stay up to date, and stay home, stay safe, stay healthy. And we hope to see you at future educational opportunities, educational webinars.
Because Michael's going to post up. I have a course next week on implant hygiene. If your hygienist is on board, they would be welcome to join as well. The details will be up on the site. Also, you could, if you shoot me an email, I'll send you the details. It'll be next Thursday. It's gonna be a morning course, Thursday the 30th.
Right, and we have a lineup of great speakers. We have Dr. Scherer giving a course, Dr. Mangalo giving a course. We have Corey Glenn is lined up to give a few more courses.
Lost in revenue over the last few weeks, you're gaining in free CE from these really top of the line people giving free CE. It's really a credit to the profession.
Yeah, we definitely appreciate the fantastic speakers who are giving the courses. Dr. Scherer is going to be treatment planning cases live on Thursday. So if you want to submit a case for live planning, then you could send it via BioBigBox to my email, msaltzman@blueskybio.com, or just email us at plan@blueskybio, and we'll send you instructions on how to do that. But if you want to submit a case for live webinar planning for Dr. Scherer, then please go ahead and do so. Robert, thank you so much for all the ongoing webinar educational opportunities, for sharing your education, your time.
My pleasure.
And thanks to everybody for attending. We hope to see you at upcoming webinar sessions.
Great, thank you.